Yeah.
Yes, sir. 3, 2, 1, start.
Very good morning to all of you. Once again, welcome to the Department of Urology, Savai Mansingh Medical College, Jaipur. So, as you all know, today we are having this session on a special day. And I wish all of you a very, very happy Gandhi Jayanti. Today, we are having a urology masterclass with a mock exam and quiz competition. And we have invited all the third-year residents from different parts of Rajasthan and the faculty also from different parts. So our today's whole program is divided into two main parts. One is the faculty talks. Will start very soon. This will be 5 talks by different faculties on very important topics which the residents will definitely benefit for their upcoming exam. And then we will have a mock exam where we will have examiners from different parts of our state and faculty from here who will be the examiners, and then we will have examinees as residents, not only from our department, but from other parts of the state also. So this will end with a quiz competition, which we will try to give awards also. And so without any delay, I welcome you all once again to this session where we will start with the faculty talks. So the first faculty talk. So I would request Dr. Nachiket, why don't you chair the session? Dr. Nachiket and Dr. Govind. Yes, please. Please come.
So, Shella, we want you to chair the first.
Yeah, we will all three be there. We all three be there. Right. So, so we start the session with the first talk by our faculty, Dr. R.D. Sahu, who will speak on the upper tract urology instruments, right? So, Dr. Sahu, please.
Thank you, Swam, sir, and welcome all.
There should not be, because this whole thing is being transmitted on Zoom and YouTube, so we don't want any instance.
So point full script. Yes.
So you get all the instruments. I think is a very important part of training in urology. Must know everything about instruments. So we have tried to. So it's very difficult to do in 20 minutes the lower tract instruments, upper tract instruments that Dr. R.D. Sahu is going to tell you about. So I have asked him to at least the basics and the brief description of the various lower tract instruments. Right. R.D. Sahu.
Thank you, sir. Now we'll start with PCNL. The PCNL starts with initial puncture needle or access needle. The needle come with different companies, different names, but 2 names with the access needle or IP needle, initial puncture needle. The length varies from the 15 to 25 centimeter with with 16 gauge or 18 gauge or 21 gauge. Generally, 18 gauge used most commonly, but 20 gauge we use sometimes, or 16 gauge but needle is used only during the all-seeing needle or micropart processor. You can see the tip of the needle on the basis of the tip. We can divide into two parts: diamond tip and bevel tip. But diamond tip needle nowadays very rare. Only few companies make this, but this is not available easily. And I was search in literature, and but I can't find anything. This the bevel needle. Nowadays, most commonly bevel needle is used. The bevel needle is a but two type. The Chiba needle, but Chiba needle has the outer sheath also beveled and stylet also beveled. You will see in the next few diagrams. While the IP needle from the Euromed, only the stylet is beveled. The outer sheath is not beveled. This is the bevel tip. Here you can see the outer sheath as well as the stylet, both are beveled. Here in lower this, and here you can only see the stylet is beveled, but the sheath is not beveled. This is the Euromed 18 to 25 centimeter. Here, but this is the IP needle. By you can see here the bevel tip, but the sheath is not beveled. But in the Chiba needle, you can see here the outer sheath as well as the stylet, both are beveled. But this is called the Chiba needle, or but this is actual IP needle or initial puncture needle. The Chiba needle or the bevel tip, both parts has a few disadvantage, like it when we puncture it, so it bends but towards it bevel tip, or when we make the puncture, if the stone is filled with stones, if the calyx is filled with the stone or impacted, so there may be a partial puncture. Or when we push the guide wire, the guide wire may go one side. So, but this is all about the axis. Diamond tip has the if we have the diamond tip needle, the path remains always straight. The path will not bends but towards the side. Dilators after the axis one needle, but there are different dilators. The facial dilators, but then Amplage dilators, then metallic dilators. The facial dilators, these are multi-steps, means one by one, not by a single step. They are used only during the initial steps, from the 6 to 14. They comes in 6 French to 16 French or 18 French. The advantage of this, but these are very cheap. But disadvantage is because they have the pointed button tip, so they may cause perforation, or if your guide wire is not so strong or not resistant, but they may cause perforation. The second is the Amplage dilator set. The Amplage dilator set is the initial 3 or 4 dilator with the facial dilator, or while others are Amplage dilator from around 20 to 30 centimeter. It starts from generally 12 French, but 12 French to 30 French, or with seats. The generally but 10 dilators with 7 seats sets. The advantage is that, but this is the we can use it multiple times, but they are much cheap, and they are semi-rigid as compared to metallic alkane dilator. So, but there is least chances of the perforation. There may be perforation, but they are less perforation. This wire of 8 French, this is known as the cobra wire. After the pushing the guide wire over the guide wire, we push this cobra wire. This cobra wire is of 8 French. Over the 8 French, all of these diameter goes over it. We push one, but then pull it, but then push. So this is the multi-step. So but there may be bleeding, or because this we can see this tip is a conical, so there may be a partial dilatation of the tract, especially in the calyx which is filled with the stone or very impacted stone. So there may this is multi-step bleeding and partial dilatation. This is the side effect. Alkane dilator. This is the most commonly used, especially in Asian countries. In our department, we have the stored one, the stainless steel 1+8 configuration. 1+8 means the first, but this is the central rod. The central rod, it is about 58 centimeter in the tip. But this has a bit bead or like a knob, so which is of 9 French. But this is of 7 French or 8 French. So you can see in this. But these are the telescopic dilators. These start from this is the 7 French, but this is 9 bar, but 12, 15, 18, 21, 24, 27, and 30. Or over this, after the desired dilators of the track, we can use the implantable seat as we desired. The advantage of these are the very cheap, because we can use in multiple times after autoclaving. The disadvantage is, but there may be perforation, and because we cannot control our force or the pressure, so but these may lead to the perforation because of the hard end of this, and but there may be kinking of the guide wire. But the patient who has operated once or before, these dilators are very safe, and we can make the tract where the fibrosis is there.
We have less time. So
Yes. But this is the balloon dilator. The balloon dilator. The advantage of but this is a single step. So, but there is less bleeding because it is a radial type of the dilator. The screw dilator, but these are also was single step, so less bleeding. Now, rigid nephroscope. These instruments, the made of stainless steel, now titanium but titanium with stainless steel are better. So, but these are the lightweight. The sizes were standard PC size range from the 20 to 70 French with length 18 to 25 centimeters. Or the eyepiece configuration, we can divide them parallel type, but this is the parallel type, and oblique or Marvisor type. But this is the oblique Marvisor type, and this is the oblique Whistler type. But this only provides advantage like these and this. If we have the pendulum camera or beam splitter, but this is the beam splitter. So, but this is the tail. So it may. The angle of the view. Angle of the view is the important part. Angle of the view means if we see from the eyepiece, so what the angle we will see. But this is it was 6 degree downwards means so but this is required angle of the view downward, because all of the instrument come from the 6 o'clock position. So we have to see the instrument early, and if it is the straight looking or forward looking, there may be perforation of the surrounding organ, or we have to see sometime calyx which are lateral or medial, so we have to see downwards in with angle with stars. This angle is of fixed almost 6. Why Wolf is 12 to 25 and with Olympus was 7 degree. The optics is of rod lens was system. Working channels were decayed according to size 8 to 12 from some the storage instrument from the store. The seats are not integrated with the telescope, so we cannot use. While the Wolf and Olympus is integrated, so can be used without seat like this. You can see the storage one, but this is only having the nephroscope, any telescopic part, no seat around this, so we cannot use it independently. If we use the forceps or the equipment will come out from here. And but this is the Olympus. We have this in our department. But this is the 22 French, or this is the 26 French seat, or this is the adapter. If we want to use only this telescope, the adapter is used. Now the semi-rigid ureteroscope. The parts eyepiece may be straight, oblique, or lateral offset, the same as Marbiger and which the body it has a light post and working channel. The light post, working channel, irrigation channel in stores type all are with the in body with store channel. The working channels, they may be common or dual. The common means the irrigation and working channel are in the same. While in dual, the irrigation channel is separate and working channel is separate. The seat may be stepwise or stepwise. The Wolf or the storage, the storage are with stepwise. Means the gradual transition of the seat from the tip to the from the distal to proximal is with steps. Means from the tip it was 8. If we come proximal, it was with 10. If it is gradual, then it is known as stepless. The tip design of the all ureteroscope is of angulated bulbous tip to make entry atraumatic in the ureteric orifices. The fiber optics, the vision and emulation with fiber optics angle of view in a stall with 6 degree, Wolf with 5 degree, and Olympus is the 7 degree. The advantage of this fiber optics, large field of the vision, faster irrigation, and large working channel. This is comparison study. Yes. This was same Marbiger, Wechsler, and the straight. But this is the tip with bulbous tip, angulated. This is showing the Wolf type with Marbiger. This is Olympus in our department, and but this is also in our department with the storage. Important mini bar. This is important. Guide bars serve two purposes: provide access and will serve as a guide over which the other instrument can be pushed. The size starts from the 0.018 inch to the 0.013, 38 inches, and in length ranging from the 125 to 260. 260 generally used in the vascular access. The parts, the shaft and the tip. The shaft is the hardest part, and while but tip may be soft, it may be jet tip, angulated or straight. But tip length is the short part. It may be 13 to 15 centimeters. The shafts are rigid. The shaft has the two layers. The outer layer is one lubricious and a highly flexible layer, which is made of the plastic or the PTFE coated and tightly coiled stainless, or may be tightly coiled in stainless steel spring wire. But this is only for the PTFE guide wire. In what Teramo or zebra wire only the core, inner core, but that is also known as mandrel, and it made of the nitinol. So we can see this is the PTFE jet tip with the zebra. This is the pteroma with the straight tip. But after the stripping its seat, we can see here the these are the software in but pteroma the short portion of the inner core becomes tapered, so it provides the flexibility. While in the jet tip, the inner core with spring coil, here only we have the spring oil, and here the no core, so it provides the flexibility. But this is the zebra, and here we can see only tapered portion of the inner core, no any spring is present in the zebra and pteroma. This is the hard part. We can see here spring, but this is the inner core, also known as mandrel. It is made of nitinol. The nitinol is the alloy, is also known as a smart alloy because it has the shape memory. Means it will resist any kink or the shape if external forces applied. So we can see the zebra and what pteroma has kink resistant. This we can see. The disadvantage of the PTFE is it may be traumatic, kink movement, but difficult to recognize. Why? But this in the zebra we can see, but it has the only disadvantage that when if the IP needle becomes stirred, but there is a coating stripped off in the large piece, but this may remain in the PCS system, and this is not good. Or in pteroma, the very slippery, so poor handling, movement difficult to recognize. But in zebra, we can see the movement because of the strip line. The cost wise, but this is the costliest. Thank you.
Thank you, Ravi. So, all of you, if you have any question, we can have a discussion now. In the meantime, I will request the next speaker to have his presentation. So, guide-wise, as you said, we have another guide, the sensor guide, where the initial tip is like a demo, and the rest is like a stiff wire, etc. So that is very useful, particularly when you are not able to negotiate with Jeremo or Zebra by passing a stone in the equator. So sensor guide-wise. About the different types of nephroscopes, we have acquired super nephroscopes also. We have all sizes of super nephroscopes where we can do super work, where we can do PCNL without removing a single fragment. So everything gets suctioned into a module. So we are using it regularly, and that's, I think, is revolutionary in PCNL. This is again one of the recent advances in PCNL where we can remove all the fragments without even picking them. All right. So yes.
It's just like the sensor, there's also the road runner. The road runner is also just a modification of sensor. I mean, it will help you to negotiate between spaces to tell us. And there is also another modification which has come flexible relator scopes, the by-wire. So you have a flexible tip, you have a stiff center part, and then you have a flexible end also. So it does not injure your squares. And
It is one thing about is the flexible scopes. So flexible scopes are a very important part of the armamentarium in urology. We do not have even just a simple RA for RAS and all that. We now have digital chip-on-chip device uteroscopes, which are very, very handy, and I think the vision is also wonderful. So I think these are some of the instruments which probably would be very helpful in our urology. Yes, Neeraj, you want to say?
Well, what has been said about the guide wire, as which guide wire you should use in your initial, learning, and once you get into practice, whether you should be using a stiff guide wire or a super stiff guide wire. Having said that, I think The most important thing is your technique of surgery, whether it's your appropriate puncture, your entry into the PCB. Guide wires at best play an ancillary role in your surgery, but nothing can replace your proper surgical technique or accurate puncture, which calyx to go from the calyx. But of course, if you have access to all these guide wires, it makes your life definitely very easy. Right. Thank you.
A very good morning to all of you. Now we start in the instrument of the lower urinary tracts. Most common and first instrument in the lower urinary tract is the cystoscope. Cystoscope has 5 components: cystoscopic seat, which is 23 centimeter in length; cystoscopic obturator, which is 26 centimeter; bridge 6 centimeter; light cable, and telescope. Telescope is 30 centimeter in length and 4 mm in diameter. This is the cystoscopic seat. In the cystoscopic seat, initial distal 10 centimeter, there is no marking, and after that there is 1 centimeter apart marking up to the 13 centimeter. So there is total 23 centimeter of length of the cystoscopic seat, and there is a color coding of the cystoscopic seat. We will be discussing in the next slide, and these are the marking numbering. In this numbering, if it is the 20 French cystoscopic seat, so there is a 2 5 French uretic catheter can be put, or 1 6 French uretic catheter can be put. If the alveolar bridge in the C2. And there is a difference between the cystoscopic seat and the OIU seat. In the OIU seat, there is a sharp cut, while the cystoscopic seat has a bulbous tip and the long beak. And in the BIU seat, there is a 1 centimeter marking from start from the tip of the seat. Diagnostic cystoscope is the 17 French, which is also known as the universal cystoscope. And there is a color coding of the cystoscopic. 17 French is yellow, which is the standard diagnostic; 19 French is green; 20 is red; and 22 is blue; and 25 is white. And on the seat there is a mention in the 20, which is commonly used, 20 French seat, red color, in which 2 5 French catheter and 1 in 6 French catheter. If the Elbrans bridge in situ is free. And most common question on the cystoscopic seat: why beak of the cystoscopic is bulbar tip? Because of the atomic insertion of the under the vision through the meatus, and not only prevent urethral wall abrasion, but also lift the upper urethral wall up and show the urethral passage. And why there is a long beak space in the cystoscopic? Because due to the project out different degree of the telescope 0, 30, and 70, 120. What is the difference between the 17 French cystoscopic seat and 19 French cystoscopic and onward? 17 French cystoscopic seat has short beak, while the other seat has long beak. So 17 French cystoscopic seat can be used in the female cystoscopy. There is a difference. 17 French cystoscopic has short beak up to 2 centimeter in length, while the 19 French onward cystoscopic seat had long beak. Obturator, there are 3 types of obturator: cystoscopic seat obturator. What the difference between the cystoscopic seat obturator and the BIU or QRP seat obturator? Cystoscopic seat obturator has length same length as the seat, and there is a groove for irrigation present in the cystoscopic obturator, 90 French on beyond. But on the BIU seat and QRP seat, there is a no groove for irrigation, and they project just beyond the seat. This is a bridge. Bridge are 3 types: bridge with without channel, with one channel, and with single channel. Bridge with bridge are the universal bridge. They can be used in any size of the cystoscopic seat. Use of bridge without channel, there is a limited use only for diagnostic purpose. And if the bridge has channels, so they can be used for bladder biopsy or the uretic catheterization. This is a Elbrans lever. This is used for the difficult uretic catheterization and can be attached to the seat for 19 French onward. Female cystoscopy can be done by 3 methods. Either we can use 17 French cystoscope, which is the universal and has short beak, or nickel adapter. This is a nickel adapter. This is applied after the cystoscope introduced in the urethra. Then nickel adapter is applied on the meatus. So there is a no seepage of the fluids. And the female cystoscopy can also be done by the OIU seat. Next is the telescope. telescope has color coding. First, 0-degree telescope has green color coding, and 30-degree has the red color coding, and 70-degree is yellow, 120 is white. 0-degree telescope is used for the ureteroscopy, 30-degree used for the TRP, TRBT, and the for the base and lateral bladder, 120-degree used for the anterior bladder neck. But due to the Hopkins rod lens system, use of the side viewer angle, so we can see by the 30-degree telescope. There are difference between the conventional and Hopkins rod lens system. Conventional lens, glass rod act as a lens, while in the Hopkins rod lens system, rod lens, air space act as a lens. Conventional lens has a thicker shaft profile, while the Hopkins is a smaller shaft profile. There is a narrow view angle on the conventional, while the Hopkins rod lens system has wide viewing angle. So there is a no need for the 70 and 120-degree telescope, while the Hopkins rod lens system has better image resolution. Hopkins 1 and 2, Hopkins 2 is a more glass columnar and new version, and there is a wide view angle, higher resolution, and they are autoclavable. After the prolonged use of the telescope, there is a micro cracks in the scope. If we use we dip in the side X, there is a fogging occur. So newer Hopkins type 2 lens system can be done by autoclavable. Saxe optical ureterotome BIU set, which consists 5 element: outer seat, obturator, 0-degree telescope, working element, and blade. You can see there is a 1 centimeter marking start from the distal tip. While there is cystoscope, there is a no marking in the distal 10 centimeter. And this is 21 French size. Generally, we use the passive working element for the OIU seat. OIU, because there is a less injury to the urethra, and 0-degree telescope is used for the OIU. Obturator, generally obturator require when we negotiate the OIU seat in the through the meatus, because OIU seat is a sharp edge. After the negotiating the urethral meatus, we can put the telescope and working element inside the seat. There are 4 types of the blade for the OIU. Success cold knife straight blade, most commonly used for the soft structure and cutting during the returning back in the passive motion. Another one is the cold knife round shape half moon. Half moon seat is for the dense structure for the bladder neck stenosis, and the prerequisite for the cold knife round blade, there should be cavity beyond the structure, and bladder should be distended. And it is used by going in, coming, and out, cut to and fro in motion. Another one is the Ludwig's straight knife waveform, which is useful for the dense structures. Accessories for the Saxe ureterotomy seat: half moon seat. Half moon seat can be applied on the 17 on the 21 French the OIU seat. Then the diameter become 23 French. And for this accommodation of the seat, there should be diameter more than 16 French. It is used when we can anticipate a difficulty in the ureteric catheterization after the OIU. Generally, when there is a false passage. And another one is the continuous irrigation seat. It improves the vision during the bleeding by the outflow, because in the OIU seat there is no outflow, only there is inflow. There is a question: why pass 5 French ureteric catheter through the BIU seat? What is the advantage of the passing the ureteric catheter? So when we pass the ureteric catheter through the BIU seat, so we will confirm that the catheter is in the bladder, so urine will come out. This is a relative step, can negotiate the structure, has marking, so can confirm the length of the structure. Zebra can create the false passage, and thermo may due to the slippery nature may coiled in the prostatic fossa. This is the Otis ureterotome. Otis ureterotome has a sharp distal hub. There is a thumb grip knob, and there is a rotating knob. Generally, length of this Otis ureterotome is 16 centimeter and 24 French diameter on the rotating side. For accommodating the Otis ureterotome, urethral lumen should be 16 French at least. and we can dilate the urethra from 15 to 45 with a clockwise in nature. It is used in the inside the urethra and urethral stenosis in the female. Knife does not protrude beyond the surface of the instrument in a fully deployed position. In the exam, examiner always asks how to put a knife in the Otis urethrotom. So you should, residents should practice how to put the knife in the Otis. This is a 4 type of, now we come next to the bladder stone. So bladder stone, there are 4 terms which is commonly used: cystolitholepexy, or there is intact removal of the stone. Next is the cystolithotripsy, mechanical crushing of the stone. In the cystolithotripsy, there is breakage of the stone by the energy source, and cystolithotropy is the open removal of the stone. This is a Mormire stone punch. Mormire stone punch has 20 French diameter, and it has on its obturator working element. There is a visual obturator, and this Mormire stone punch requires 0-degree telescope. Movement is forward and backward, and the stone up to the 2 centimeter size can be crushed by the Mormire stone punch. So it has on its outer sheath visualizing obturator and working element. It is a sturdy, therefore bigger stone can be crushed. Movement is forward, backward, and prerequisites for the Mormire punch is the bladder should not be empty. Bladder should be full, and stone is grasped, lift from the base of the bladder and move all around, so that there is no chance of the bladder mucosa to come in the punch. So there is so this can cause urethral bladder mucosa injury if the bladder mucosa come in the punch. Another one is the stone crushing forceps. Tip is like the alligator jaw and move in the upward and downward direction. This instrument requires a 0-degree telescope. Third instrument is the Hendrickson stone lithotrite, which is obsolete now. It has to pass blindly, and there is a high chance of the creating false passage in the urethra. It uses the 70-degree scope, and if the jaw is stuck, we need the open surgical removal, but now it is obsolete. Alex evacuator and the Toomey syringe. Alex evacuator used on the mechanism of the Adich current, and a Toomey syringe has the highest suction pressure. If there is a large clot, organized clot, so by the help of the Toomey syringe vacuum, we can remove the clots. And when we are using this Alex evacuator, the tip of the sheath should be elevated in the bladder by depressing the shaft. This is a resectoscope. Component of the resectoscope: 20 French continuous Iglias resectoscope sheath, which is a outer penetrated sheath, inner sheath with backlight tip, visual obturator, working element, active and passive, and the telescope. There are different way of classifying the resectoscope depending on the size: 24 French, 26 French, which is a yellow in color, and 27 French and 28 French, which is a black in color. Depending on the beak, they are short, long, oblique. Depending on the sheath material, Teflon and metallic, Teflon and ceramic. Depending on the type of irrigation, conventional and continuous, and depending on the rotating or not rotating. 22 French integrated resectoscope, color code white, is available for small size urethra. Depending on beak, if there is a long beak which occludes the bleeder during the resection, so poor vision. In the oblique, in the modern resectoscope, there is a oblique beak. Depending on the material of the sheath, backlight. Original Eastern McCarthy instrument use the backlight, but this is the fragile and susceptible to the easy breakage. Teflon has better durability and non-conductivity of the electricity. And we most commonly now commonly use the MTC, metal, ceramic, and Teflon. Distal portion is made of the Teflon, which is non-conductor, and rest of sheath is made of the metal, which gives the strength. And inner portion of beak is coated with ceramic, which is the heat resistant and a non-conductor. Conventional resectoscope has not hedge the outer sheath, so there is a need for frequent emptying of the bladder. These are nowadays not used. When these are when in the previous era, when the conventional resectoscope was used, so we put the SPC needle rotator cannula to outflow of the channel. Now there is a continuous irrigation resectoscope. Outer sheath is added for the drainage of the irrigation fluid. This is work on the two principle. Inflow is come from the inner sheath and the working element, and outer flow and egress of the fluid come from the penetrate distal tip of the outer sheath, which has a fenestrated hole, and the fluid enter in this fenestrated hole, come between the inner sheath and outer sheath, and come out from the outlet. So this is enable resection continuous and uninterrupted. Advantage: avoid any built-up pressure inside the bladder, keep vision clear, and quicken the procedure of TURP. This is the continuous irrigation resectoscope sheath with the inner sheath and outer sheath, and this is a conventional irrigation resectoscope sheath. Rotating resectoscope, in which the inner sheath and the working element is rotate inside the outer sheath. There is no rotation of the outer sheath, so there is a less injury of the less torque on the urethral wall, and the less chance of the urethral stricture, or there is no entanglement of the tubing due to the rotation. Working element, most commonly used, there are three types of working element: rack and pinion type, which work by to and fro movement of the lever, but nowadays we don't use this. There are mainly two types: Nesbitt type, passive or thumb operated, and another one is broom wrapper, active or finger operated. For the Nesbitt type of passive, for the learning purpose, initial learning curve, we should use the Nesbitt type passive working element, because there is a no loop remain inside the seat, so there is no injury to the urethra or the bladder, and the chips are cut in the controlled fashion. Speed of resection slightly slower, and the passive Nesbitt type working element can also be used in the OIU sheath. And finger operated broom wrapper, this loop remain outside sheath in the resting stage, and there is a resection is fast. Resection can become deep if the surgeon exerts more pressures. There are three types of the obturator: visual obturator, which is commonly used nowadays, which is known as SIMDET, allow the pass resectoscope under the vision, indication watching institute learning in the institute for the learning person when there is a large median lobe, pulse passage after traumatic cystoscopy and dilatation of the urethra. Another one is a straight distending obturator used. इसमें locking of the obturator cause rubber cup to distend outside the sharp margin of the outer sheath, so there is no injury to the urethra and the bladder. And third one is the Timberlake obturator, which is a hinge movement and used in the large obstructed median lobe. And the last is cutting loop. Cutting loop is a make of the fine tungsten wire. Its size range from 0.3 mm to 0.4 mm, and 0.35 mm is the extender. Loop for 0 degrees straight and 30 degrees curved. 24 French and 26 French resectoscope use yellow color loop, which is 24 French in diameter, and 27-20 French resectoscope use the brown color loop, which is the 27 French. And the thin loop is used when we need the precise and the sharp cut, generally in a TURBT, and the when we are dissecting apical lobe of the prostate. In the monopolar, we use the tungsten loop, and in bipolar, we use the platinum and iridium loop. And type of loop is tender cutting loop. This is tender cutting loop, which is used in the TURP and TURBT. Calling snipe, which is used in the BNI, TUIP, bladder neck stenosis, ejaculated obstruction. Roller valve, which is used for the hemostasis, achieving hemostasis. Moving loop, which is used whenever there is a tumor in the posterior bladder valve, because it is a straight. Conical electrode for point coagulation. Sharp curettage and blunt curettage when there is a slug on necrotic material. So we use these loops. So in the exam, there is always asked how to assemble the resectoscope. So whenever you assemble the resectoscope, first align the obturator into the inner sheath, because inner sheath has a backlight tip. If you put the inner sheath on the outer sheath directly, so there is a damage of the backlight tip. After that alignment, inner sheath and obturator assembly to the outer sheath. So always practice to assemble the resectoscope. Thank you.
Because this is all being transmitted on Zoom and YouTube. So thank you, Somen. Thanks for that wonderful presentation of lower tract instruments. There are many things to be added, I think, but it was a brief presentation. He tried to concise it as much as possible. And we have now bipolar, monopolar, we have HOLAB, using morcellators. All these things are, again, very important part of the lower tract urology armamentarium. So any last comments from the chairperson, please? Yes.
Sir, I think that this is very important from the examination point of view, just because the residents, especially in the last minute, you will always be asked how to assemble instruments, and then there'll be a problem if you put an OIU sheet or if they put the inner sheet of the sector. So be careful. And this is one segment in which if you know even the basics, then you can score very well. Right. So I think that as we had already decided, we'll be sharing all these presentations with everyone. It's free education for all. So if you want, you can download these presentations, and I think that there will be benefit in the exam. Thank you.
Thank you. Thank you, both of you. So I would request now next set of chairpersons, Dr. Bhatt, please. Bhatt, Dr. Ritesh, and Dr. Neeraj, please come. So we all know it's very important in exam where we sometimes lack is the uroradiology part. How to read properly a CT scan, MRI, and these I think where we fumble or have some problems sometimes. So we have requested our faculty from SMS Medical College from Radiology Department, Dr. Naresh Mangalhara, to please enlighten us a little bit about the basics of CT and MRI in urology, how to read them, and which is important for the residents' point of view. Yes, Dr. Mangalhara, and I would request the chairperson to go ahead.
Thank you, sir. A very good morning to respected HOD Shivam Priyadarshini sir, my all seniors, my colleagues, and my dear juniors. So my topic of talk is uroradiology, but to complete uroradiology in 20 minutes is literally not possible. So there are various aspects of uroradiology. We can divide in diagnostic uroradiology and interventional uroradiology, and there are various modalities in diagnostic uroradiology like X-ray, USG, Doppler, IVU, RGU, MCU, CT, and MRI. As the program is basically for benefit of MCH students, I will keep my talk focused on the CT and MRI only. So before I go to examination technique and imaging protocol, first of all, I will like to show 3 images of the same patient of a with renal protocol. So my question is from any of the residents, can you pick up any difference in these 3 images? Can you notice the difference in parenchyma, difference in collecting system, difference in vasculature? In these 3 images, they belong to the same patient and with the same scan. So basically, if I talk about this image, if I ask to anyone that what are these hyperdense structure? Extraction. So if I say, if I am not telling about the which is exactly which phase it is, and I am saying that is NCCT phase, then what will be the diagnosis? Right. So, and if I say that it is a delayed film, then it is normal expression of the contrast. So basically, the imaging interpretation depends on the timing and various phases of the renal protocol of the CT scan. Right. So basically, there are 4 phases which are related to the kidney. One is the enhanced scan. Second is corticomedullary phase, nephrographic phase, and expiratory phase. So for a renal protocol, we usually give 100 to 120 ml of the contrast. It should be given rapid bolus injection with a rate of 3 to 4 ml per second. And oral contrast media is usually not recommended because most of the time positive oral contrast media overlaps with the ureter, and the detection of the ureteral pathology become masked by these oral contrast media. Similarly, when we see the vasculature of the kidney, then also the oral contrast media may hinder the interpretation of this vascular structure. So usually we should avoid the oral contrast, oral positive contrast. Basically, we can give water or oral neutral contrast like water, and it should be ideally given 500 to 100 ml of the water can be given 15 to 20 minutes before the start of a renal CT examination. This water usually helps in the better distension of the renal pelvic calcium system and better delineation of the pathologies. So first, our first question is non-contrast CT scan. It is usually, as we all know, that it is regarded as the primary imaging modality to detect urinary tract calculi. However, its role is not limited to only the renal calculi. It is also important for diagnosing areas of hemorrhages and renal hematomas. It has also its role to know the basic HU density measurement of renal masses. It also helpful in knowing renal parenchymal calcification, fat attenuation, and calcification if present in any renal mass. So the American Association and Urological Society guideline for the surgical management of stones specifically recommend that non-contrast CT should be obtained before performing PCN in adults and children. Second, the first contrast phase, it is corticomedullary phase. It usually comes after 25 to 80 seconds following the contrast administration. In this, basically these phases are the normal physiology, how the renal system show normal physiology. It depends, these phases depends on the physiology of the kidney. So in this phase, the lumen of the proximal tubules fill up with the contrast, which then enters the cortical capillaries and peritubular capillary spaces. So in this phase, only the cortex enhances, while medulla does not enhance. So we can differentiate between the enhancing cortex and an enhancing medulla. So this phase is basically when this phase is important. So whenever you need to see any vascular related issues in your scan, then it is very important. Like if you want to see the tumor hypervascularity, then this phase is important. Similarly, vascular invasion by the tumor can also be very well evaluated on this phase. Sometimes it also helps in differentiation of normal variants and pseudo tumors from the renal masses. However, there may be limitation of this scan also, like sometimes hypervascular cortical renal cell carcinomas may show the same enhancement as the normal renal cortex. Similarly, many times small hypervascular masses are located in the medulla, and they may not enhance and they may not pick up on this phase. Then comes the nephrographic phase. It is an important phase, comes after 90 to 120 seconds after the contrast injection. In this phase, the contrast passes through the renal tubules during this phase. So there is homogeneous enhancement of the whole of the renal parenchyma. And we cannot differentiate between cortex and medulla on this phase. And this phase is very important, especially for detection as well as the characterization of renal masses. And on this phase, any enhancement more than 20 HU is considered suggestive of malignancy until proved otherwise. And the lesion enhancement usually best visualized on this phase only. Apart from the renal masses, other pathologies like renal infection, traumatic parenchymal lesions, acute pyelonephritis, etc., can also be well evaluated on this phase. Then comes the excretory phase. It begins with the excretion of the contrast material into the collective system, and it is usually best seen after 3 to 5 minutes of the contrast administration. And this phase provides a good delineation and visualization of the pelvic calcium system. So when this phase to be evaluated, whenever you are suspecting any urothelial lesion, including neoplasms, or you are suspecting some calcium deformities, papillary necrosis, and strictures and inflammatory changes related to collective systems and ureter, then this phase is very important. So there are few examples of the phase. This is NCCT phase. We can very well see that radiodense opacity in the left ureter, and we can also see on the fullness in the pelvic calcium system of the left kidney. And this coronal image, we can very well see that there is hyperdense focus in the mid-ureter level, and it is causing upstream dilatation of the ureter as well as the PCS. So once your suspicion was calculi and your examination is over, you need not any other phase for this patient. But in this patient, we can see there is a large mass lesion almost replacing the left kidney. And this corticomedullary phase, we can very well see that the hypervascular foci in this masses, this mass. Also, we can see the hypotenuse defect, filling defect in the IVC, so which may indicate the vascular invasion by the mass. So this phase is important for this purpose. Similarly, this is nephrographic phase of the renal protocol. And we can see some hypodense lesion in the right kidney. This is non-enhancing. This lesion may be any cause which may lead to focal pyelonephritis or focal devascularization due to injury or anything. But we can pick up this lesion on this nephrographic phase. Similarly, we can see the diffuse non-contrast enhancement in this right kidney. These cases are usually post-traumatic, and they diffuse insult, they represent a diffuse insult to the kidney, like the traumatic and devascularization of the pedicle. And in this case, we can see that there is a hyperdense mass lesion on the NCCT, and on the contrast phase, it is showing good hyper enhancement of the lesion, which is obviously more than 20 HU. And this lesion is also showing a good washout of the contrast in the excretory phase, which is also a sign of the renal malignancies. So which phase is important depends on the clinical suspicion and the patient's clinical condition. So for urolithiasis and acute flank pain, non-contrast CT of the abdomen is the most sensitive and specific test for the detection of urinary tract calculi. Irrespective of the calcium content, almost all calculi are seen as radiopaque densities on non-contrast CT. Identification of a stone within the ureter is the most specific diagnostic finding of urolithiasis. A rim sign may also be seen in cases of calculi owing to the ureter wall edema that develops at the site of infection. A decreased density of the renal parenchyma, hydronephrosis, hydroureter, and perinephric fat standing are the other features which can be seen in cases of the calculi. CT can also differentiate calculi from phleboliths. Phleboliths are also quite common in the abdomen, and sometimes there is confusion with this is ureter calculus or this is phlebolith. So calculi have usually a dense center, while phlebolith have a center lucency. Further, a comet-tail sign, which is a linear or curvilinear soft tissue density extending from an abdominal or pelvic calcification, is highly suggestive of phlebolith. This linear or curvilinear soft tissue actually represents the thrombosed vessel, not the ureter. So this sign, comet-tail sign, is a sign of phlebolith. MDCT is also useful for detecting the causes of pain other than the stones, such as appendicitis, biliary colitis, diverticulitis, etc. If you are suspecting renal infection, then CT can tell about the nature as well as the extent of the disease. Complications such as the gas-forming infection, abscess formations, and urinary obstruction can also be well picked up on this CT scan. The most characteristic finding of acute pyelonephritis is poorly defined low attenuation areas of decreased attenuation, which are vase-shaped, radiating from the medulla to the cortical surface. So a nephrogram pattern consisting of alternative linear bands of hyper and hypo attenuation, the so-called striated nephrogram, is another characteristic feature of acute pyelonephritis. Other findings include focal or diffuse enlargement of the kidneys, stenting of the perinephric fat, thickening of Giroda's fascia, and obliteration of renal sinuses. Focal thinning of the cortex may result from scarring in the chronic cases. And if you are suspecting some renal mass, then multiphagic MDCT should contain all phases of the imaging, because the non-contrast CT, it is helpful to detect the calcification and also the baseline pre-contrast HU values of the mass. Similarly, the corticomedullary phase is helpful to define the extent of the tumoral tissue into the renal and IVC, the neovascularity, arterial feeders, and the entire arterial anatomy. It also has an accurate demonstration of the arterial anatomy, which is essential to plan a nephron-sparing surgery. Nephrogenic phase helps to characterize the indeterminate masses, and it is useful when more than 10 HU enhancement is present, then it is highly considered as a RCC. The extractive phase is also important in the suspected tumor case because it demonstrates the relationship of centrally located mass with the pelvic calcareous system. Involvement of the renal pelvis and calyces can best pick up on the extractive phase, and ECC are the best detected on this phase. And washout more than 50 HU on this phase is highly suggestive of a RCC. So viewing in multiple planes and multiple orientation can be done to obtain all the information needed to plan a surgical resection. A display of the arterial and venous anatomy is possible prior to surgery. Now, if the patient comes with a blunt renal trauma, then again the CT protocol should include all the phases, because the hemorrhage, pseudoaneurysm, contrast extravasation, renal arterial injury, or the renal vein thrombosis can all well pick on the corticomedullary phase. Nephrogenic phase is the best to demonstrate area of renal infarction, areas of non-perfused parenchymal injuries, etc. Extractive phase images are best to show contrast extravasation in urinomas, indicating an injury to the collecting system. So it is if you see a contrast extravasation in the trauma patient, it is important to note which phase it is. If it is a corticomedullary phase, then it is a vascular injury. But if it is a delayed, this is extractive phase, then it is not a vascular injury. It is a pelvic calcareous system or ureteric injury. So the knowledge of these phases is very important to reach a diagnosis. So how to improve urinary tract distension? So 10 mg of furosemide can be given 1 minute before the contrast administration, or approximately 1000 ml of water can be given orally within 15 to 20 minutes to cause sufficient distension of the collecting system in most cases. Sometimes saline chase can be given after the administration of the IV contrast, which helps better observation of the distal ureter, which is usually the most difficult segment to visualize. Image interpretation. So there are various post-processing techniques in the CT machine has evolved tremendously in the last decade. And there are so nice software and hardware installed in these scanners. They are very powerful scanners. So these post-processing things can help us tremendously, like MPR, MIP, and VRT. The reformat shows the urinary tract entirely and are useful for characterization of renal masses, presence of calculi, evaluation of ureter, and localizing of the exact level of abnormality. So few words about the image processing and post-processing techniques. So a normal coronal, this is the normal coronal image. We can see there is calculus with the hydronephrosis in the left kidney, with the thinning of the cortex, but the rest of the ureter is not visualized in this plane because the ureter is a tortuous structure. It doesn't come in a single coronal section. However, after applying the multiplanar reformats in this scan, we can see that the calculus is causing hydronephrosis, but the rest of the ureter, which is visualized still ureter, is completely normal. So this is the beauty of these reformats, that we from the raw data we can extend the design information and exact anatomical things we can evaluate. And these things are these are very important before planning a complex surgery. Similarly, these are the MIP images, and their images are mainly used for the contrast film structures like the angiographies or the when the contrast is in the extractive phase in the pelvic calcareous system and ureter. And we can delineate the whole tract in one plane. And we can also rotate it in the multiple planes, and we can take a 3D idea of the patient and its anatomy. Similarly, these are the volume rendering images. We can see how the kidney, when you will open the case, you will see how you will find the exact anatomy of these structures. So these post-processing images are very, very helpful. They help in the complex, difficult diagnosis. They also help very helpful. So I won't go in detail. So now the recent concept of split bolus MDCT urography. So what is the problem with renal protocol? That there are the four phases of the images. So 4 times patient undergo the radiation exposure. So now the new concept of decreasing ALARA principles as low as reasonably achievable. So the whole focus is to decrease the radiation dose to the patient without compromising with the efficacy of the CT scan. So now the new concept is emerging, like split bolus MDCT urography. So in this, we actually, the aim is to minimize radiation dose as well as to minimize the number of images generated. In this, we take this is basically a two-phase technique. We divide a contrast in two boluses. We give one bolus earlier, and after some time we give a second bolus, and then we take a single scan. So both the nephrographic phase and pyrographic phase comes in a single scan. So we usually first take the non-contrast scan, then we give 30 cc of non-ionic contrast as the first bolus. After 10 to 15 of the first bolus, we give the remaining contrast 100 cc contrast, and after a delay of 100 seconds, we take the sequence and which represent both the nephrographic and pyrographic phase in a single acquisition. Similarly, the new concept of triple bolus urography has also been emerging these days. In this, we split the bolus into the three parts. So first bolus is 30 ml given at 2 ml per second for the opacification of the excretive system. After the first bolus, after 7 minutes, we give the second bolus of approximately 50 ml to opacify the renal parenchyma. And after the 22nd, we give additional dose of 65 ml with for the arterial information. And after giving the three bolus, we obtain a scan for after approximately 500 seconds from the first bolus. So a triple bolus technique brings all the stages in a single scan: corticomedullary phase, nephrographic phase, and executive phase. So the radiation dose is significantly reduced. So now the dual energy CT. So this is quite a hot topic these days, and this is, I think, may be important for the exam point of view. So in dual energy CT scan, so they are more developed CT scanners, and they take acquisition on the two different energies. Most commonly used are 80 kVp and 140 kVps. And with different material density and monochromatic images, they are the complex algorithms in the machines. And these images can generate virtual non-contrast images. We do not need to take a separate non-contrast image, so it reduces the radiation dose to the patient. Further, it also helps in differentiating hyperattenuating renal cysts from the solid masses, and the water density images can be used as virtual and enhanced images, reducing the dose of the radiation dose to the patient. It is also helpful in characterization of renal stone. It can differentiate uric acid from the non-uric acid calculi. And the differentiate is important. You must better know than me that because of the different line of management of these stones, like uric acid calculi are amenable to oral medications, struvite can be managed by ESWL, while the cystine ones are very resistant to fragmentation with lithotripsy. So sometimes characterization of the renal stones are also helpful in the management. Few words about the pyrates and the MRI prostate. This is a very beautiful imaging, and it is very nice to detect the suspected prostatic cancer. However, it is very quite difficult and for interpretation. However, for MCS regions, it is important to know the at least three sequences you should know, that T2 weighted images, diffusion weighted images, and the dynamic contrast images are important for these pyrates. These days, MRI is not limited to T1 and T2. Gone are those days when the MRI was T1 and T2. Now it is a Pandora box. In every few years, there are so many new sequences like diffusion came, like susceptibility came, like gradient came, like MRS came. And this is in every few years, the new sequences are coming out. So we cannot interpret all the sequences, but for the theoretical knowledge, you should know the three sequences which are most important for the prostatic pyrates. It's T2 weighted images, diffusion weighted images, and dynamic contrast enhanced images. And interpretation is actually why interpretation is difficult, because these are the old patients and there are multiple nodules of the BPH in these patients. In all patients, when we suspect any lesion, most of the time there are already benign prostatic hyperplasia and there are many nodules. And the findings are so subtle that it takes a high concentration with a focused view, and the same focus should be correlated with all the sequences also. So it is a little bit different. But to make it simpler, I will say that if any lesion, the larger the lesion, it is more dangerous. The more it is showing restriction, it is more bad. more it is showing low ADC values, it is dangerous. Okay, and it is showing enhancement, good enhancement, especially in the early than the rest of the prosthetic parenchyma. It is bad. So different sequences are used differently in the peripheral zone and differently in the transition zone. So I won't go much deep in there because it is a little bit complicated. And there are various permutation combinations also, like the same lesion which is looking like the Pirate 3 in the T2 weighted images on transition zone. Based on the diffusion weighted images, it may be either 3 or it may go to the 4. So it is a little bit difficult and tricky. However, this is important. The interpretation of the Pirate is important. A Pirate 4 and 5 are usually indicated high chances of the malignancy. Pirate 1 or 2 are usually benign cause, and Pirate 3 is intermediate. This Pirate actually do not advise further investigation in form of the biopsies. There are no clear-cut indication in the Pirates. However, Pirate 4 and 5 usually we recommend biopsy for these cases because they are high chances of malignancy in these cases. And Pirate 3 in the intermediate category depends on the other factors like the PSA levels, PSA density, and how the PSA is trending in the last few months. Or various factors depends on the intermediate. Biopsy can or cannot be done, or follow-up can be ensured. In Pirate 1 or 2, usually follow-up is advised. So few words about intervention uroradiology also. So I will show only 2 cases. This is very interesting case. This patient last month came to our department. This patient was having history of post-pituitary anal hematuria, and CT angio was done. It was reported as normal, but the clinician was having high suspicion of some arterial bleed or some bleeder. The clinician was suspecting. So he sent the patient to the cardiology department. Cardiology department took the patient for the renal angiogram. And they also reported the case as normal. Patient was somehow managed, conservatively discharged. Patient, the symptoms didn't resolve. Finally, patient again came up with the hematuria admitted, and there was hemoglobin fall. And patient came to our department for the review and the reference of the intervention review. I missed the CT. The CT was wonderful explanation of how the post-processing data helps us in the diagnosis. We examined that CT because this is older CT, so we have lost the CT right now. But on CT angio, the same CT angio which was done 1.5 months back, we reviewed that CT angio. And on MIP images, we could notice some irregularity at some terminal branch of the lower pole of the renal artery. So we advise that we are suspecting some damage to the renal artery or some small pseudo in the lower. So we planned the case, and this was the case of the 1 month back angio images of the cardiology department. So this was the angio, and it was reported normal because CT was normal, angio was reported. But if we see, so we can see a small irregularity at this point. Can you notice? Normally, what happens? This was the same site when we suspected the irregularity on the MIP images of the CT angio, and when we reviewed this cardiology, and we can see this is more. So ideally, what happens when the arteries goes in the periphery? The caliber become narrow and smoother. Here we are seeing that this is the and here we can see the caliber is going narrow, but at this point it is little bit irregular and there is some bulging. So we planned to evaluate this case. This was our catheter, and we took the angio of the whole kidney. Then we used our micro catheter. This is our micro catheter. Its diameter is less than 1 mm. It is only 2.7 French diameter. We to this curve. We entered into the lower pole, and we selectively went into this lower pole artery. And we took angio at this point. Here we could notice that there is small outpouching in the lower pole branch. We further went closer to this is the roadmap image. We can see this white road is pseudo-annular. We went much closer as close as possible to this lesion because renal arteries are end arteries. Whenever we block the renal artery or any branch, it will lead to the necrosis of the remaining renal bed. So to decrease the nephron damage to the nephrons and to just conserve or preserve the maximum parenchyma, we went as distally as possible, and we put the coil here. We could have applied the coil here also, but it will lead to complete devastation of the lower. So with this, these microcatheters are very helpful. They are developed in the last decade, and they are very useful devices. So we went till the very close to this pseudo-aneurysm, and finally we placed coils. And this is the coil. This is the post run. We can see the other part is showing quite vascularity, and this is our final run. Post coiling, we can see the complete opacification with good nephrogram of the with only little bit parenchymal lacking of enhancement. So this is the final image. This is our coil here. Most of the parenchyma is spared. Though this patient was having a normal right kidney, even if we have blocked this proximally, then also it wouldn't might not hamper deranged renal function due to the well-preserved right kidney. But these techniques are very important when the patient is having solitary kidney or the patient's renal function are not good. So the preserving. So this was an interesting case. Finally, the patient resolved the symptoms and it was discharged. And I request to UOG department, if patient comes to the department on follow-up, please send it to. We just want to see if there any change, morphological change on USG of this post-embolization. Patient name is Manbari. Second case, this patient was preparing for some medical, government service, and he was having varicocele. So the surgery might cause him unfit for in the medical fitness. So patient came to our department for some interventions. So we went through these are the DS images. We went through the left renal vein into through the right femoral vein. We entered into the left renal vein, and through this we entered into the gonadal veins. And then we take a run, which shows that contrast is going deep into the scrotum. It is reflex basically. Ideally, contrast should not go into in the retrograde direction. Again, we passed our microcatheter deep into up to the pubic symphysis ring, and we can again run was taken, and we can see there are tortuous serpiginous vascular structure in the scrotum, the issue of varicocele. Then we planned the embolization, and we placed the coils, and then we placed the embolizing agent. And this is the post-procedure images. This is our coil. This is the blue and other embolizing agent. And this patient is currently has passed his medical examination. So to conclude, the optimal strategy for imaging the urinary tract is a matter of debate, particularly when recent development in cross-sectional urography, and it must be tailored to the patient's symptomatology and clinical context. When well utilized, then both diagnostic and interventional uroradiology can play a significant role in the optimal management of these patients. So this is our newly established vascular intervention radiology OT. And this is our DSA machine. And here, Lord Ganesha are sitting in the center, blessing us all the time. Thank you.
So wonderful, Naresh. I am sure that many of our residents would like to discuss with him. So during the break, you may, Doctor, I would request to be here. And just after the half an hour, 1 hour, there will be a break. You have a, okay. Okay, and okay, thank you. We will be there. Okay, thank you. I know the Department of Radiology at SMS is doing wonders. We have everything that they are doing in interventional radiology, even the radioablative things. They have radio frequency ablation, they have microwave ablations, everything. So you people are doing wonderfully well, and we are really proud of you. And I think this is a part which all of us should put stress on, because I request all my residents to go to the uroradiologist and see on the console what actually is happening on the CT and MRI image, because that will help you to understand the whole image much better. And now we have everything, as he said about the post-processing formatting and everything. Now we can do a virtual cystoscopy, virtual ureteroscopy, pyeloscopy. we can have a 3D image of the thing. Even with the help of a 3D printer, we can have a 3D model of the whole kidney and everything. So that all can help us a lot in planning out our surgery. So I would request now, if the chairperson has any comment, then I would request Dr. Bhatt to have his presentation.
Wonderful talk, Naresh. And having a good interventional radiologist is nothing less than a lifeline for urologists. We get so many complicated cases of post-PCNM hematuria and renal trauma. And regarding the patient that you talked about, Manpari Devi, I remember she was admitted in our unit and she was referred from somewhere else to our department. And the interventional cardiology people, they reported it as a normal CT, but the hematuria was persisting. And then we referred the patient to Naresh and he could do a good job and the patient is absolutely fine. So really wonderful work you're doing. Thank you.
Thank you. So I would request now Dr. Bhatt, please.
The only clinical work would be radiologist as well as what routine is that the routine CT is being done. So you take sections of 1 centimeter or half centimeter, you apply. And ask the residents also, you send the information to your radiologist and diagnosis. Suppose there is a renal one, you're suspecting about this one. So sections has to be taken. Many times when you suspect that the smaller lesions are being reached in 1 centimeter. So it should not be uniform. Suppose there is a tumor in the bladder. So small sections are to be taken in that area. That will help in
Exactly. That's why we have these different protocols. We have a renal protocol for renal tumor. If you're suspecting a renal tumor, ask the radiologist to have a renal protocol CT scan rather than having a normal CT scan. So it's very important, I think. And I would request all of you to have that software downloaded also, Radiomics, where we can have video clips of all our CT imaging and MR imaging. Yes. Yes, Dr. Bhatt, please go ahead. Each time Dr. Bhatt loads his presentation, we have Dr. Sandeep, who will speak on renal transplantation, and Dr. Devendra Sharma, both are Dr. Devendra would speak on RNS. Yes. So he would speak on RNS. And then we have a small break, we'll have tea along with some little music, right? We have a lot of talent in our department, and we all know today is Gandhi Jayanti. So a small bhajan, 5-minute bhajan along with tea. And in the meantime, we will try to prepare the 4th floor seminar hall for the mock exam. So I will request my residents to escort all the faculty and the residents, make batches, and take them up on the 4th floor after the finishing floor. Right? Thank you. Thank you.
First of all, let me compliment and congratulate urology department that media rarely praises, especially the medical one. I am happy to see the full coverage in the Times of India today for urology department, special mentions about the robotic. I compliment and congratulate, and I wish that they go ahead with the same pace as they are going. And now the talk goes about the hypospadiology and hypospadiology.
Double screen आ रही है सर एक्चुअली दो screens आ रही है सर
Will it be okay?
सर इसमें ट्रांसफर करना है फाइल
शुरू करो
So in the meantime, when the file is being transferred, you can just
I'll
spot it in
start.
your exam.
First of all, let me tell you that hypospadias surgery is a very simple one. Don't be afraid of it. It is more simpler than your endourology. You see how this endourology and lab started. Lab started with this one. People started, they said, if there is, then we'll convert. But here you already have. You prepare the patient because most of the time, the problem is that there is a failure and the parents and the relatives are after you. So you already tell them that there are two surgeries. And then you go ahead and do the surgery. Even if you do initially in 30% cases, then you increase it to 40% and 50%, the patients will be happy. So this is only the way you tell the patient and convince them. And there are very simple things on this one that you have to read the genitive. Everything is written on that one. You just have to look for it and do it. Second important point is in that one that you won't have to do something very extraordinary or something. Think that what could have been the embryology and what could have been the thing. This is the arrest of the embryological development of the urethra and the penis.
So that it's going through the Zoom.
Yeah. So that is through the, so that's what is. So just look for that, and rather than doing anything heroic, you just try to do what nature might have been done, might have done. So that's what simple principle of doing hypospadias surgery. If you follow this one, then you will get the answer of most of the questions. So in my talk, what I will do, what I'll see, how to see, look for it, what could be the problems that you will have to analyze, what's minimal investigations which are needed, and what are the indications of
I think everybody, one of you knows WhatsApp. WhatsApp is one of those packages in our country were made a little made Mr. Proud because he has been working and going to workshops almost all over the world. And is part of editorial board, he is part of many of these committees, which are international committees on hypospadias. So we are really proud to have Dr. Mirza with us today to speak on hypospadias.
So that was the thing that you have to just convert it. So what I'll concentrate on, how to examine the patient, what investigations are to be done. And there are two things which important is. One is the cardiac correction. Another one is the reconstruction of the urethra. So as far as possible, cardiac correction, what the myth goes on that one. So we never understood hypospadiology. We have to understand the hypospadiology. What we are doing at, there are only two things which we done: denial degloving, dorsiflexion. That is not the method. So we have to evaluate what is the cause in particular case. And another few of the important things are that one will have to remember that there is no replacement of the urethra. Urethra is the only replacement of the urethra. And if we can reconstruct the urethra, which would have been a native urethra, then that is the best thing which you can do it. And that how can you do it? That is what I'm going to take in these nuances of hypospadias surgery. You can take that one. They will not accept it. Apple. So Apple will accept only in Apple.
इससे अपने वाले में नहीं हुआ अपने वाले में वो फिंगरप्रिंटिंग
This is a technical problem, right? So, because this fingerprint is not matching, so it is not going into our lab. Right? Anyway, and then because it is being transmitted through Zoom, it is difficult to have other laptops get connected. Parts of Rajasthan, we just have a small introduction of each other. Please. Yes.
can do one thing. Why don't you raise that?
Good morning, everyone. Good morning, respected teachers. Thank you for having us. I am Dr. Anurag Yadav, MC's third year president from SMS UROLOGY. Thank you for the privilege.
Good morning, everyone. I am Dr. from SMS.
Myself, Dr. Himanshu, third year resident from
Myself, Sushant Tripathi, and Mr. Padi from AIMS. Good morning, everyone. I'm Dr. Pujit from SNMC Jodhpur. Good morning, everyone. I'm Dr. Amit Soni, third year MCS resident from GMC Kota.
Good morning, everyone. Myself, Dr. Abhishek Chauhan, third year urology resident from Government Medical School. Thank you for such a wonderful idea. Thanks.
Good morning, everyone. I'm Dr. Sanil Punia from Mahatma Gandhi, third year resident, and thank you for having us. Myself, Dr. Sujit from Mahatma Gandhi.
Good morning, everyone. I am Dr. Yupal from Mahatma Gandhi, third year.
Good morning, everyone. Myself, Dr. Patel from Mahatma Gandhi. Good morning, everyone. Myself, Dr. Sushin Patel from Mahatma Gandhi.
Good morning, everyone. This is Dr. Krishnan from Mahatma Gandhi, second year.
So all of our residents, you also introduce to other residents. Go ahead. And yes, so the other residents may be let you know.
My name is Pankaj Chauhan.
Good morning, everyone. I'm Dr. Gaurav Palta, third year resident. Myself, Dr. Sabir Singh, third year resident. Good morning, everyone. Myself, Dr. Sabir Desai, SMS Medical.
Good morning, everyone.
Good morning, myself,
Good morning, everyone. Myself, Dr. Sal from
Myself, Dr. Shamsi, third year resident. Dr. Rahul Singh, third year resident. Good morning, everyone. Dr. Sajid Gulwani, resident department of urology, SS Medical College.
Good morning, everyone. Dr. Ansri from Mahatma Gandhi Medical.
Myself, Dr. Abdul Modi,
Folder.
So we all know today is Gandhi Jayanti. So I once again congratulate you Greetings from the Department of Urology on this very pious day. When such a great man was born in our country. I'll just give 2 or 3 quotes of Mahatma Gandhi. In the meantime, they are ready with their presentation. So I would request any one of you, if you remember any of the quotes, just please let me know so that we can have as many quotes of Mahatma Gandhi as possible. So if anybody remembers, what I remember is one is he said, live as if you were to die tomorrow. Live as if you were to die tomorrow. And learn as if you would live forever. Right? So if you want to have change in the society, he said, you must be the change you wish to see in the world. So begin it with you only. That is very important. If you really want to change, then it has to begin with you. Another quote, happiness is when what you think, what you say, and what you do are in harmony. So happiness is when what you think, what you say, and what you do are in harmony. So in the meantime, yes, thank you, Doctor.
I'm extremely sorry for wasting this time because there was some problem of Apple not allowing this one. So thank you. With that, then I'll just proceed ahead. What has been one time, these were the 4. You might have not learned this terminology, mafia. And this terminology was given by Dr. Braca. In most of the international meetings, we 4 were the people. Warren, PP, Braca, and me. So he blamed us. Braca gave the name. These hypospadias mafias will leave no cases unturned anywhere in the world. So this will be my talk will be concentrating. So as I said you that in-depth study of hypospadiology that still remains, and I wish that youngsters you should take up this one and learn more. Hypospadiology is still to be learned, and this is the normal. You see the fusion of the urethral plate from proximal to distal that forms the urethra with the proliferation of tissue, and if there is any abnormality in this one, then that will lead to this one. As I told this one, another important point is that as far as possible, if possible, preserve the urethral plate and the tissue which is there available that may be hypoplastic. In many a time that may not be hypoplastic, there is a good one. Then I'll show you in many cases that people say that don't find the spongiosum in primary cases, and I find hypospongiosum in most of the reoperative cases because that has not been taken care and looked for. That is a boom for me, but that's so one has to sue. As I said you that you will have to evaluate site of the opening, size of the glands, size of the urethral plate, where the opening is. And another important thing is that many a time that if you think that opening is somewhere here, looking like, but it's not by this way. The true sense is division of the hypospadiasis after correction of the curvature. And this is that one, what you call distal one, middle one, and proximal. This terminology is followed commonly. Why I have put all these, I have collected and put this one, but it is not the real classification. Real classification and division on which you will decide your surgery should be after phenyl declaving, and then you see where the meatus lies, and accordingly, and especially the thing which is being neglected is the proximal hypoplastic urethra. That length may be a few millimeter, means 5 millimeter to a 1 centimeter and 2 centimeter. So that part has to be taken care in what procedure you are going for. Then variants of the hypospadias. There are different variants. You see, this is what is chordae without hypospadias. What that definition is, the prepuce is formed, the penis is well formed, but there is a curvature. So that is chordae without hypospadias. Then there is a webbed penis with chordae without hypospadias. This penis is totally buried. You see, if you retract it, then it's totally buried. And then there is megameatus intact prepuce. Then other variants are in female also, female hypospadias. You find the hypospadia opening is opening into the vagina. And then a traumatic one. Traumatic hypospadias is also a very big group which is usually being neglected and pushed as a OPD cases. So whenever there is, that is usually due to catheter trauma, or in children it is because of the circumcision, or many a time the foreign body tying a thread or some rubber band for this urinary incontinence, then that happens. So that is the cause of the iatrogenic hypospadias. So then it's urethral plate. Urethral plate, you have to divide that one, because urethral plate is a very important point which decides the repair of the hypospadias. So there is the favorable urethral plate. Urethral plate is usually wide. And what is that favorable is that if you can tubularize the urethral plate without incision, and if a superficial incision means incision in the urothelium itself, then that is a favorable one. Then there is an intermediate one where there is sometimes tissue between the urethral plate and the opening. And then third thing is that unfavorable. Here there is hardly any urethral plate. So these are the things which decides the hypospadiology, because in first and second intermediate, you can go ahead, preserve the urethral plate, utilize, and you can do with the tubularization of the urethral plate. But rest of the cases, either you have to go for the flap plate repair, or you will have to decide that the two-stage, if you are not confident of going for the single-stage flap repair. So these cases needs that one, unfavorable. Then the evaluation. When to go for this one? Rest evaluation is okay, routine evaluation. There are three things which needs the, one is the endocrine evaluation when it's to be done. Second one is the radiology when it's to be done. And third thing is that hormonal in these cases when has to be. If this is the type of this one cases, so these needs the hormonal. Here you see, this is an important sign. If there is a bifurcation of this, then if you see there is a dimple one. If you can see this area, there is a dimple. Dimple. So this is a sign of the hypoplastic vagina lying inside. So this is my sign which I have given. You see, this sign means a dimple in the perineum, or there is a bifurcation of the median raphe in the perineum. So these patients are to be needed to be evaluated for the DST cases. If not DST, then the Mullerian duct remnants. These are to be evaluated. In those cases, maybe that you will need the genitogram, you will need that one, the MRI and ultrasound to have the detailed study of this one. So this is what you are saying. Another one is if there is a complete penoscrotal transposition. So these patients need, you see here, if we do the radiology, then there is a vaginal pouch, genitogram done, and this shows even the hypoplastic vagina and going this one up to the fallopian tube and going into the. So these are to be tackled there on that stage. Otherwise, these are going to create problem in hypospadias repair. You see, the size of the penis is important. This is it. This nomogram which I have dictated and produced with my results in Indian population. You go with this nomogram. If the penis size is smaller than this, then you give the hormonal manipulation that may be local or systemic. What you want to need that one. That's rough cough regime or 5% I usually go for the 5% local testosterone cream. That is good enough. And these patients, especially this one, you see, in these cases, you will have to go for endoscopy also. Just going before, many a time, maybe that radiologically you miss that small vaginal pouch that will create later on, forming the incontinence, post-hypospadias repair, dribble of the urine, recurrent urinary tract infection, and many a time forming the stone. So see if there is, here you can see if you do endoscopy, this is looking like two openings, and here you find that there is another opening. So this is full vagina. So this has to be taken care during this surgery. Magnification is an important. You see, the key of success is commonest cause is fistula. And whatever you do, you add 1 layer, 2 layer, 3 layer. If you have not done a good approximation of the urothelium, and to have a good approximation of urothelium, you need magnification, and that makes the difference. So you use always one, and then is important is hemostasis. If your surgery has this after post-operative, there is a hematoma, then whole part of the surgery is being spoiled. So create during surgery, you use micro, or I usually use the local adaline, and you can use the adaline gauze to have a full hemostasis, and post-operatively apply a minimal pressure dressing that prevents the hemostasis. So local adaline is good enough. Then suture material. Number one thing, you forget about those things. Number one, catgut is out of question. Non-observable suture is out of question. Only the absorbable or late absorbable, that is vicryl and PDS. Suture, smaller one, 40, 50, 60, according to the age of the child, that is the best one. And type of suture doesn't matter. The continuous or this one, whichever you want to use, you are comfortable with. The only thing is that you approximate the urothelium nicely. If there is a proper approximation, there will be less chances of the complications. Then diversion. Many a time, many books and literature, you will find that no need of putting in catheter. Yeah, the urethral stent. Urethral stent has to be put on, especially in our conditions where there are the hospital infection, post-operative, they don't know how to care this one. Even the peripheral doctors, they don't understand what hypospadial surgery has been and how the post-operative care is. So it is a better, safer to put in a urethral stent. Suprapubic diversion is rarely required. In my whole career, I hardly put twice or thrice. That is only if the accidentally perurethral stent comes out and you are not able to put in this one. And that is not the thing that the suprapubic will allow to heal or something. The basic principle is approximation of the urothelium, and there should not be any extravasation. So if you these two things, if you can put the via naturalis any drainage, then that is the best one. Then size dressing. Dressing is a very important part, especially in our centers where there are more chances of the hospital infection and post-operative also. So that has to be covered with the sterile gauze with the lubricant gauze inside, and that pressure has to be adequate one. It should not be too high or too low. So in our circumstances, what I use, this is the dressing which is not available. This is the best way of going for dressing. Either use the micropore or you can use the Dynaplast. I usually do this dressing, send the patient in within 24 to 48 hours home, and patient comes for the dressing removal after 7 days. That's all that is needed. Then rational approach in decision making. As I said, there are three things which you will have to take into consideration. Is that what is the type of hypospadias, means what is the location after penile decline? What is the length of the hypoplastic implant? What is the severity of the curvature? And fourth, what is the status of the urethral braid? Accordingly, you will have to choose the procedure which is needed. And objective, nothing said, one has to have, the objective should be that the penis of the patient should be as close to the normal as of a normal child. And that is right of that child. We'll have to give the right of that child. And this is the algorithm with which I go usually. And then I told you, first point is correction of the cording. As I told you, what commonly is being done, that is not on the embryological basis or surgical principles of surgery. So let us evaluate and see why unnecessary. If you are doing this one application, that causes, and the biggest complaint of all hypospadias and epispadias patient is short penis. And by doing application, you are again shortening the penis. So do only when it is needed, and I'll let you know when it is needed. So there are times when you do application, there are chances of injury to the nerve, and there is excessive bleeding also if you incise the corpora. So how to go ahead with that one? You see, let us see what are the causes of the curvature that may lie in the skin, dartos fascia, buccal fascia, spongiosum, or corporal disproportion, dorsoventral corporal disproportion. So you think by doing penile degloving and dorsal plication, are we correcting these causes? No. And if you are not correcting these causes, then when the child is adult, then there are likely that there will be recurrence of the curvature. So we'll have to correct the cause. So how to go ahead with that one? So steps is you do penile degloving, then mobilize the urethral plate and spongiosum as it is spread lateral one. Then if there is a corpus spongiosum segment short, then do a proximal urethral mobilization and see. And after that, if there is, then you see that is a corporal disproportion, dorsoventral disproportion. Then these are the cases where you need either a corporotomy or a dorsal plication, not in all cases. So let us see what I am telling. Is it, if we go step by step, can we correct the curvature? Let us see, we can correct. This is the normally seen moderate to severe curvature. You will find if we go normally going, okay, penile degloving to dorsal plication. No, it is not needed. You go like that one, and even in this case, you see how severe. If it is looking like normally, if you go, then you will transect the urethral plate and do a two-stage repair. And if you go step by step, you have mobilized the urethral plate. And why to sacrifice this spongiosum? It's so good as spongiosum. And if by spongioplasty, if we go by that one, then tubularization and spongioplasty reconstruct a normal urethra, and that's what our ideal is. Then you see this one. Here you see this glandular part. Rest of the thing is corrected. And when you mobilize it, the glandular body is being corrected. Still, you have preserved the urethral plate. But if you go normally by saying, then after penile degloving, what you do? Dorsal plication. Then midline dissection. If you go, that what could be? The causes of in buccal fascia. Buccal fascia is attached in the midline. So what you do is they dissect in the midline and dissect the buccal fascia on the lateral side up to the lateral border of the this one glans or the corpora. So what will happen? The glans, where the glans wing is going laterally, that will help you in giving the glans plasty. That I'll also let you know. So at that place, if you do the lateral dissection, the causes of the buccal fascia is being covered. Then a glans plasty, this one, this spongioplasty. You see, spongiosum is spread like Y. Y, if you make that Y into I, that will give you a length. And that's what happens. It's not theoretical. It looks like, you see here it is, and you see this one. You are getting the gaining the length of the urethra on the ventral side. Then glans plasty. See this one. You do glans wings are like this one. And when you do a glans plasty, good plasty, what will happen? This will rotate like this one. This will rotate like this one, and will push the urethra distally. And that will correct the curvature of the glans. That is not possible by anything, even by your dorsal plication. That will be, if there is a glandular chordae, that has to be corrected by just a good glance plastic. Now comes that even after doing all these things, then you do dorsal plication. You may argue that if you have to do dorsal plication, then why to go all these steps? There is a reason. You see, if you see the combination, the factor may not be in one. There may be a combination of factors which are responsible for the curvature. And if you have corrected the curvature causes of the Buck's fascia, Darto's fascia, and the spongiosum segment, then there is only corporal disproportion which requires the corporatomy or a dorsal plication. Then length of the dorsal plication will be short. Even with a single stage dorsal plication, you can deal with that, and your job is done. And we achieve our target of not shortening the patient penis too much. You see these cases, simple, by preserving the urethral plate, and we could have corrected. Now, these are the cases where there is hardly any poor urethral plate. In these cases, there is no urethral plate. So what you have to do, you have to transact the urethral plate, and then how to correct this. You see what happens. Again, people do penile declubbing and do dorsal plication. What you do, you transact the urethral plate at the corner, dissect the urethral plate along with the spongiosum anteplayer of the Buck's fascia. So that will correct the causes of the Buck's fascia and the spongiosum segment, and whatever the spongiosum which may be of a 1 centimeter or half centimeter or 1.5 centimeter with the urethral plate, utilize that to have a good anastomosis in the vascular space and cover that anastomosis with that spongiosum. So this you're secure proximally, because if you go in a single stage or even in the distal stage, so what will happen? That is the cause of the site of the fistula in these cases. So that part is to be taken. If you are even going in 2 stages, and if you preserve some part of the urethra and urethral plate, that will give you an added advantage, that if you can bring that, because if you will see the long-term complications of post-void dribble, the retained ejaculate, and all these are more common in flap repairs and 2-stage repairs, because that you don't have the urethra with the spongiosum. If you can create a urethra with the spongiosum up to the penoscrotal junction, then rest of the part is by gravity. So you can avoid all these complications. So that is the importance of going for, and this is what you are doing. You see mobilization of the urethral plate, there is a tethering. You did this transaction and chordae is being corrected with midline dissection. And here it's by penile declubbing and mobilization of urethral plate and spongiosum. You see there is this is the part and this is part of the spongiosum, which you can utilize. And this is by lateral dissection of the Buck's fascia. And here you see so severe a curvature that is corrected you need not to go for the dorsal plication or corporatomy. By just going, that means what we are talking is we have corrected the etiological factor and corrected the chordae. This is again similar one. And now again in all these cases also the dorsal chordae plication or corporatomy or corporoplasty is to be taken only as a last step. So let us summarize that. What happens? These are the factors which we discussed. So penile declubbing corrects the curvature causes of the skin and dartos, mobilization of with the spongiosum, lateral and midline dissection of the Buck's fascia. The Buck's fascia causes spongioplasty and granuloplasty. They again help in lengthening the spongiosum segment. So there's the spongiosum, and then superficial corporatomy or corporoplasty. This is the in gist of the curvature correction, and you go step by step. Then is even in secondary cases, I told you, you see this is operated case earlier, and you find that there is such a good spongiosum, and you after doing this one correction of the chordae, you see after mobilization you can have retraction on one side, you correct this one midline dissection, chordae is being corrected, and you do a tubularization of the secondary urethral plate and spongioplasty. Then is the TIP. What we are going earlier, what I have been given by the Western literature and going simply that tubularize that urethral plate. No. Are we going, what our aim was? Are we doing the same thing that as what embryologically has been left? You have to complete that job only. That means the urethral plate is open, glans is this one, the spongiosum is spread laterally, and that is attached laterally to the glans, and prepuce is hooded. These are the problems. Let us sort out these problems. And if we sort out these problems, then the normal penis is covered. And if we go by these step by step, what I mean, if we go step by step, then we create a or reconstruct a normal penis, and that is our objective. You see, this is, you won't have to go for complete penile degloving in all cases. If there is a minimal chordae or no chordae, you do only because what you need, your working area is this one. Why to go dorsally and dissect unnecessarily? This is what is, then you do a partial penile degloving. Second one is mobilization of the urethral. This spongiosum is very, very important. This one, you start just distal 1.5 to 2 centimeters proximal to the meatus, and then go and dissect this laterally going spongiosum and dissect proximal to distal and medially. Medially, it is not always necessary to lift up in all cases. You go up to the midline in those cases where there is no curvature. If there is a minimal curvature, then you lift up and then you correct the body and go into the glans. You see, our objective is to create a normal urethra up to the neomeatus. And this is very, very important because if you do a spongioplasty at the corona is the commonest site of fistula. And if you cover that area and go with the spongioplasty up to tip where you are creating a normal meatus, then that is the ideal one. And that prevents the fistula. And then incision depends upon if you are giving superficial, no need of the inlay. But if there is a deep incision, because deep incision, this is what is not, I don't go by that the Western literature, what they say. If there is a deep incision, if you are going up to the corpora, and if you are giving deep incision into the spongiosum, then what will happen? That is likely to fail. Why? Because when there will be the spasm, there will be extravasation. Extravasation will be in the spongiosum, and that will lead to the fibrosis, and that will lead to the stricture. So better is if you have to put a deep incision, then put a graft. And that's how you can put it. The interficial skin graft is the best one. And if not available in secondary cases, then you can put the buccal mucosal graft. And then spongioplasty. Spongioplasty, key of points. And this one is tubularization. I think first I'll take this tubularization. Yes, this is important. First, tubularization. There are important key points in tubularization. You have to start the tubularization at least 1 centimeter proximal, where the bifurcation of the spongiosum has started. When you will start tubularization at that place, the urethral plate distally will come in closer by itself. And then spongioplasty. Spongioplasty, you have to start at least 1 centimeter proximal to that one. Why this is important? Because if you start tubularizing at the site of the meatus, then what will happen? There are chances that there is fistula. That is the site of the fistula commonest. And if you start proximally, then you are tubularizing at the meatus, and then you do spongioplasty over that. Then there are least chances of that one. And then spongioplasty that has to go up to the tip. Then frenuloplasty. This is what, if you are not doing complete penile degloving, do a glans plasty, and after glans plasty you are coming down, then you are creating a frenulum. That's what you need, that you can create a normal one. And this is glans plasty 2 layers you do with a wide one, you can put the forceps where when you are putting suture, then that creates this one, and then dartosography. The literature says, and Western people say that you bring a dorsal dartos and cover. You see, dartos is same, whether that is dorsal or ventral. If you have done a good mobilization, even in a partial degloving, and if you get this one, you see this is the thickness of this spongiosum. You see this thickness of this spongiosum. If you can do this this dartosography or the dartos cover from the ventral, then why to go for this one? And this is this thing of the dartos. So why to go for the dorsal one? Because if you are going dorsal, then there are chances that you will compromise this blood supply of the dorsal surface of the penis. And then this is a preputioplasty, and with preputioplasty, you reconstruct the almost a normal penis. So this I have already covered, and these are the results. You will hardly see that they are even know that they are being operated. Then TIPU is possible in proximal hypospadias. As I said, that the decision is not by the site of the meatus, decision is by the width of the urethral plate, spongiosum development, and if you can tubularize and correct the chordae without transecting the urethral plate, go and tubularize that one. That is the first choice. That should be done. Then proximal, you can do this one. This is proximal covering with the dorsal dartos cover. This is proximal with the double dartos cover, and this is proximal. And if you are thinking it's one, and if you are going a long one, better you put the tunica vaginalis cover, and that will prevent your fistula formation. And even in many cases, you see here, you see this is the dartos which is covering on, and you are able to do even the preputioplasty. So that's what our aim is. That's what we should do, is that one. Even in redo cases, TIP is feasible, and spongioplasty is feasible. You just look for, and the best key again is that you start the mobilization of urethral plate and spongiosum proximal to the meatus. Find a plane of dissection at the deep level of buccal fascia, go laterally, dissect it, and you will get the spongiosum, and you can go and do TIP. Even in redo cases, you are able to do spongioplasty, and you cover with the tunica vaginalis, the job is done. These are the results in redo cases. So I just put it summary. Our purpose is to create a normal glance in that one, and that is with the TIP. The one more word with this, that as I told you, spongiosum is rarely being, you see people say that there is spongiosum. You see, in all cases you can find. You just have to look carefully. This, I have marked this. Spongiosum is seen even by skin. And when you do penile degloving, you are able to see the spongiosum. See the spongiosum and dissect it, and then get, and there are only two, and these can be divided into poorly developed, moderately developed, and the well-developed spongiosum. And the mobilization, I have told you, the spongioplasty. As I showed you spongioplasty, what the disadvantages conventional spongioplasty is: tubularization of the urethral plate, spongioplasty, and skin cover. All three comes in one line. As per principles of fistula, if there is any leak anywhere, then there is likely to have fistula. So can we prevent? And a second disadvantage is that one, you see, the urethra is cylindrical. And what we do after spongioplasty, that urethra becomes the triangular one. You see here, it becomes a triangular one. Can we prevent it? Yes, we can prevent it. How can we prevent it? Go for a double breasting spongioplasty. Well mobilized spongiosum one, tubularize one segment of the urethral plate. You just suture just lateral to the tubularized urethral plate, and then cover breast over. That's just like double breast, and the suture lines are being covered. Advantages are two. One is that you can see this one. You can nicely tubularize this part. One side is being taken. There is a good sponge, another one, and this part is being covered one. Again, this is, you can see This is, you can do the double breasting. What the advantage is, if you do double breasting, you have advantage that you are covering the new urethra with two good flaps, vascular flaps. Suture imposition is avoided. Urethra become cylindrical. All these things which we wanted, we do it. That is being done. Even in secondary cases, as I told you, that this is the, when you mobilize and preserve the urethral plate, this is the urethral plate which you can do anastomosis, cover this with the spongiosum, and your job is being done. Even redo cases, you can do it, and this is post-operative is there. My message to all youngsters is go with the normal one. The best or worst part in the what I find in the literature, people don't go for spongioplasty, and tubularization with spongioplasty can create only a normal urethra. That should be your objective. And with this, thank you very much for giving this opportunity to have an interactions with the youngsters. Thank you.
Thank you, Vatsal. That was wonderful. In the meantime, I will request Dr. Devender to kindly, his presentation is ready because we are running short of time. So I would request the last two speakers to be in time. And yeah. So we all know Vatsal, please. You must have seen in all of these slides his book, Hyperspadiology, Principles and Practices, published last year only. And this is one of the books probably is a very, I think we need to have it as a prized position for all the urologists because he has described each and every aspect of hyperspadiology in his book. So that's a wonderful thing. And yes, Dr. Neeraj, if you want to have some comments, and Nachiket, and then we will start the next. Yes.
Regarding
it's already on.
regarding spongioplasty, sir, I have a small query. We have been doing spongioplasty, but the difficulty that we face is doing spongioplasty in the glands. In the proximal part of the urethra, the spongiosum is very nicely visible and you can approximate it. But once you enter that glans area, the spongiosum is not that well delineated. Yeah. This is one of the issues that even we talk about it to the residents also.
Yeah, in the break, we can have a discussion on that. So we will try to start the lecture as soon as possible. You all know Dr. Devender Sharma, a very senior urologist, passed out from SGPGI, working as a senior consultant and director at R.K. Birla Hospital and C.K. Birla Hospital. And I have come to know that C.K. Birla is also trying to get a robot, right? Da Vinci XI robot. That's great news. And I think we have a lot to learn from Dr. Devender regarding retrograde intrarenal surgery. He has done a lot of workshops throughout the country on this particular surgery. And he has been doing all kinds of surgery, renal transplants and everything. So welcome, Dr. Devender. And please.
Thank you, sir. Thank you for your kind words, and thank you very much for giving me this opportunity. So, first of all, I would like to tell you that RIRS of flexible ureteroscopy is just an extension of semi-rigid ureteroscopy. Only the mindset need to be changed while doing flexible ureteroscopy because this instrument is delicate, lasers are there, and there is a tip moment up to the 260, 270 degree both way. So my presentation will cover about the instrumentation, what are the indication, do's and don'ts in RIRS, tips and tricks, and difficult cases if time allows. As all of you know that in any endourological procedure, we need a guide wire, cystoscope, ureteroscope, three-way stop with syringes, contrast agents,
laser machine, baskets, ureter dilator, ureteral access sheet, suction pump, video camera, ureter fluoroscopy. This is the basic instrumentation which is required while we are doing flexible ureteroscopy. Out of them, 4 which are in different color, that is laser machine, basket, ureteral access sheath, and flexible ureteroscope. These are the 4 things which is required primarily for flexible ureteroscopy. Rest of the instruments always available in all endourological suites. What are the indications? If we divide the indication into 2 parts, diagnostic and therapeutic. Many times we see cases with persistent microscopic hematuria, and we don't do anything on imaging. Normal, we can go for flexible ureteroscopy. We will diagnose few cases in our practice where we clinch a small tumor in the pelvis or in calyces. Coming to the therapeutic indication, as all of you know that the most nuisance thing is post-residual, post-PCNL, post-lithotripsy residual calculi, which are tiny fragment, but it always bothersome to the patient. So in these cases, if you have flexible ureteroscopy, already these patients are having a stent, the ureter is dilated. In those situations, you pass flexible scope, take out those stones, and you can satisfy the patient, and you can get the 0 residual stones. Coming to the renal calculi, as AUA and EAE guideline says, the stone less than 1.5 centimeter, which can be dealt with primarily with RIRS or lithotripsy. Cases with infundibular stenosis, these are really post-procedure cases where post-PCNL or post-open pyelolithotomy. Many times you find superior calyceal or middle calyceal infundibular stenosis very difficult to handle with other methods. If you have got flexible scope, then it's very easy to manage with flexible ureteroscopy. Diverticular stone, again a challenge for PCNL. So it's a good tool to have flexible ureteroscopy, and you can do diverticular stone with flexible ureteroscopy. I always say the most important part of any procedure in case of flexible scopy is the consent and counseling. This is the most important part. Always talk to your patient yourself, explain all pros and cons, all advantages, because what mindset patients have is that there is no complication with flexible scopy, there is no incision, no pain, no complication. Always explain to the patient that there are chances of complication also. So this is very, very important part. Second is DJ stent alone. You probably, if you find a narrow ureter, your narrow ureteric orifice, no need to dilate in these situations and forcefully enter into the pelvic system, because this might damage the ureter, which is the very important part of pelvic system. So better we take a consent from the patient that in 5 to 7% of cases we fail to pass our flexible scope. In this situation, we just put a DJ stent and will come out. The DJ itself will cause passive dilatation within 7 to 10 days. You can again go after 7 to 10 days and take out the stone. Always take consent for additional procedure. Again, this is an important part because you cannot guarantee any procedure. Like in lab, we always take consent for open conversion. Similarly, in flexible scopy, always take consent for PCNL also. As already discussed, complications should be narrated beforehand because mindset is important for surgeon as well as patient, because they come to you that you are not going to create any complication, but always tell that these are the complications of flexible ureteroscopy. And last is the DJ stent removal under general or local anesthesia. This consent should be taken beforehand because many a time patient comes again, it's dab sa pehle to aapne isko pehle bhi stent ke liye aapne OT mein liya, again you are taking it to the OT. So this should be explained to them that DJ stent removal can be done under general anesthesia, because after 15 days, if you are removing stent and you see some fragments lying into the pelvis on the X-ray or in the ultrasound, it's better to remove at the time of DJ removal. Anesthesia and preoperative evaluation of these patients, all RIRS should be done under general anesthesia preferably, because in spinal anesthesia, because of pelvic calcium dilatation,
patient always have discomfort and pain at the time of surgery if it is being done under spinal anesthesia. And second, many a time we need to have apnea, especially stone is lying to the superior calyx in those situations because movement is very fast because of respiration. If you are doing under spinal anesthesia, then we don't have control over the respiration. So if you are doing general anesthesia, we can ask anesthetist to hold give apnea for some time, and you can do laserize the stone very fast. Coming to the imaging, the preferably for if you are doing RIRS, the imaging should be CT scan, either non-contrast or with contrast. It doesn't make much difference, but imaging is as preferably CT because of two reasons. One, it can pick up the small stones and exactly tell us that where the stones are lying. Second, we can know the hardness of the stone. If Hounsfield is more than 1000, then be cautious. If you are dealing with a bigger stone and it's hard stone, better to go for PCNR rather than going for RIRS. So if Hounsfield unit is less than 1000, we can go for RIRS. And last is urine culture. Always have a documented urine culture before procedure in RIRS. We may skip in other procedure. Ideally, it should be done in other procedure also. But for RIRS, always get a documented urine culture trial, or if it is positive, give antibiotic for at least 48 hours to 72 hours before the embarking upon procedure. The next is the ergonomics, because it's a if you are dealing with a bigger stone, it's a long, tedious procedure, and it takes a lot of time when you are lasing the stone, especially bigger stones. It takes time. So if you look at the OT setup, you should be more comfortable. The camera should be at the straight at your head level so that you need not to rotate your neck. Otherwise, there will be a lot of neck strain and the shoulder strain. Keep your arm alongside your body. If you look at the movement of flexible ureteroscopy, as in semi-rigid ureteroscopy, there is in and out and rotational movement. Along with that, there is a deflection movement also. This is the third dimension of semi-rigid ureteroscopy, which is added into the flexible ureteroscopy. In the right side kidney, if you are doing, then calyces always look on the left side. So you need to rotate your arm, wrist on the right side. And on the left side, you need to rotate and pronate your wrist. Coming to the access, this access usually can be done after balloon dilatation under fluoroscopy, endoscopic dilatation with the help of 6 French ureteroscope. In principle, if you are able to pass 6 French ureteroscope through ureteric orifice, in those situations, invariably you will able to pass 9-11 ureteral access sheath. Guide wire, preferably in flexible ureteroscopy, by wire should be used if you are railroading the flexible scope over the guide wire. But if you are using ureteral access sheath, then by wire is not required. Safety wire, to begin with, if you are doing any procedure like PCNL, you should use safety guide wire, but it's not mandatory. The next question comes with the ureteral access sheath versus no ureteral access sheath. It's a debatable issue in flexible ureteroscopy. There are two groups. One group is using the ureteral access sheath. Nowadays, almost 70 to 80% of people are using ureteral access sheath, and 20 to 30%. Grasso et al., their group is not using ureteral access sheath. The point in favor of ureteral access sheath is facilitate the entry and re-entry into the pelvic calyceal system easily, maintains the intrapelvic pressure less than 30, decrease the operative time, optimize the overall success rate, and decreases the wear and tear of the scope. But the disadvantage that it requires free stenting in almost 30% of the cases, and chances of ureteric injury is there. So this is a basic photograph of ureteral access sheath. There is a inner obturator and outer sheath is there, which is hydrophilic, and it's so different ureteral access sheaths are available. Doesn't have much different in all of them. You need to select the size depending on availability of flexible scope which you are having. So Basically, if you are using fiber optic scope, 9x11 unilateral access is good enough to accommodate the flexible scope. If you are using digital scope in those situations, because digital scope are bigger size, in those situations, you need either 10x12 or 12x14 unilateral access sheet. If you are using 12x14 unilateral access sheet, always pre-stent is required. Baskets, which is very important tool for retrieving the stones and relocating the stone in flexible scoping. It's a tipless nitinol basket, vital for the success of RIRS. Tipless design prevents trauma to the mucosa, preserve tip of the deflection of the flexible ureteroscopy. Whenever you pass something through the working channel of the flexible scope, it decreases the deflection of the flexible scope. If you are passing a basket, it doesn't change the flexibility of the tip, flexible scope. It helps in relocation of the lower polar calyx into the superior calyx or favorable calyx with basket, which enhances the efficiency of fragmentation as well as the life of the scope. As a rule, in principle, if you are doing flexible scopy into the inferior calyx, chances of damage to the flexible scope is more. And even if you are passing flexible scope, you can see the stone. Moment you pass laser, there is little bit decrease in deflection, so you cannot laserize the stone into the inferior calyx. So it's always better to relocate the stone from inferior to superior or middle calyx, whichever is favorable. Favorable means where your scope is straight, preferably, and your laser fiber is going in easily, and there is not a big space into the calyx, so that it does not move here and there. So these are the different kind of baskets. A lot of baskets are there. In general, the first encircle basket and engage basket. These are the two useful baskets. This basket has got a tip grasping at the tip. So this can be useful as we are using in PCNL and ureteroscopy. So you are more comfortable with this basket. With encircle, it's little bit difficult, and you need to have a learning experience to how to engage the stone with this basket. I think video is not going to run. Okay. Oh, it's coming. So this is how we insert the basket. We are along with the basket, there is a conical tip comes, which we insert into the working channel here. This saves a lot of baskets because this is the most resistant part, and many times if we are inserting, it's a very soft basket, it damages the basket. Most of the invariably we damage the basket at this point. Coming to the flexible scope, initially there were two types. Now there's three types of flexible scopes available. One is fiber optic, where fiber bundles are there, another chip on tip or digital scope, and third is digital disposable scopes. Nowadays, this is also an important tool which we have got. Flexible scope durability is questionable. Initially in my residency days, the recommendation of this life of flexible scope used to be in books. It's 15 cases for flexible scope, especially for fiber optic. But if you have one single assistant, if one single surgeon, if you are handling it properly, you can extend it up to 100, 150 cases also. Fibers are broken during extreme deflection. So be cautious when you are dealing into the inferior calyx, because you don't, many a time you press the lever so much that it damages the fibers. And develop leak, especially if you are passing laser fiber in a band scope. Sometimes you pass fiber into the band scope, then it causes damage to the inner working sheath of the flexible scope. Broken fiber not only limit the ability to perform ureteroscopy, but also result in costly repairs. So only the Olympus gives the repair facility, but it usually costs 3.5 lakhs per repair in general. So these are this is a busy slide, but a lot of flexible scopes are available. If you look at tips and shaft diameter, these are the flexible and this is the digital. Again, this is fiber optic and this is digital. If you look at digital scopes are invariably around 8.4 to 8.5, and Fiber optic are a smaller size. Length is almost similar. Working channel is almost similar. 3.6 French. No difference. Deflection, initially there was little bit difference. Nowadays every scope have got 270 to 275 deflections, and viewing angle is almost same. So if you look at the difference, it's the only side shaft diameter. So which is lower in the flexible scope and more in the digital scopes. Look at the vision. This is the vision of fiber optic scope, and this is the vision of digital scope. There is a huge difference in the vision in both the scopes. Coming to the tip movement. The deflection mechanism permits maneuverability in both the direction, and this deflection is usually provided by several wires running down the length of the endoscope and attached to a lever. So you move the lever and it's moved likewise. So there are two kind of movement. Nowadays, most of the scopes have intuitive movement, means down. If you are pressing the lever down, the tip is going down. If you are pressing the lever up, the tip is going up. So this is intuitive, another is counterintuitive. There is significant loss of ureteroscope deflection, that is 7% to 16% and 18% to 37% for 200 micron and 365 micron laser fiber. Nowadays, there are new laser fibers are coming like flexible attractive, which claims that it does not change the deflection of the flexible ureteroscope stick. Coming to the irrigation, this is another part of flexible ureteroscope, which is different from the other endoscopic procedure. Like this is the 40 centimeter water height. This is the flow. You can see it's a good flow, 3.6 French, without any instrumentation. Moment we have passed, this is a 200 micron fiber, which we passed into it, and see the flow. So initially it was a good vision. Moment you pass some instrument into the working channel, the vision is lost. So what we need for this pressure irrigation. This is another one important devices which needs to be there when you are doing flexible ureteroscopy. There are different mechanical pressure devices. 40 centimeter of water is safe, but sometimes you cannot see a good vision with 40 centimeter of water, and different pumps are also available. And in the last, this very important part, leak test. Usually this is being done by technician, but leak test should be done after every procedure. Moment you find some leak at the end of the procedure, you should send the flexible scope for the repair. Otherwise, damage will be more severe. And if you pick it early, then the cost of the repair will be less. This is how it's being done. The instrument comes with the flexible scope. You attach to it, increase the pressure, and leave it there only. Watch if there is drop in pressure or not. If it's dropping, then leak test is positive. Again, regarding sterilization of these scopes, because infection is really a big enemy for flexible ureteroscopy, you have to be very, very careful while handling this instrument for sterilization of these instruments. So preferably ETO should be done if you have got ETO, otherwise plasma sterilization and other things are also available. For Sidex, usually Sidex is, I don't use Sidex, but it's recommended glutarate LDL 2% for 20 to 40 minutes is important. What should not be done? This is very, very important because we are switching from rigid to flexible scope, no force. Whenever you are feeling you need to push hard in any part of the during the procedure, don't just leave it there, put a strain and come out. Never pass laser fiber and bend scope. I'm repeatedly saying this thing, but invariably the first damage to the scope happens because of this thing. You pass flexible laser fiber in a bend scope. Urethral access sheath should not be going into the kidney. It should be 3 to 4 centimeter below the PUJ. Many a time we pass up to the kidney so that it will come out like it comes out with the PCNL. No RIRS in active UTI. Be cautious with large stones. Large stones means for flexible more than 1.5 centimeter only. Once you gain experience, you have done 100, 150 cases, then you can switch to for the bigger stones also, but with all precautions. Be cautious for inferior calyceal stones also. The safety and efficacy of stage retrograde intraoral surgery is a study in which they studied stone less than 1 centimeter, 1 to 2 centimeter, 2 to 3 centimeter, more than 3 centimeter. If you look at size, as the size increases, clearance rate decreases, and number of the repeated procedure being done is more. So this few of the photographs were larger stone, but if you look at the fluoroscopic image, it's a soft stone. This patient's hospital unit was 750. That's why we took chances and it went down like anything. Coming to the complication, infectious complication is a real problem. Despite all advancement in laser, flexible scopes, and all technology, this incidence is not going down. So intraoral pressure and operative time is the most important limiting factor for RIRS. Positive midstream urine culture, infection stone, large stone burden, force irrigation, which we usually use for the better vision, and prolonged operative time. These are the risk factor for UTI in RIRS. This is few of the photographs. There are urethral access sheath and urethral lesions. There are type 0 to type 3 injuries which were described by Oliver Traxler. So type 0 injury like this, like look at this happens when we are doing semi-rigid ureteroscopy also. So this 53%, almost half the patient will have this thing. And 33% just mucosal eversion is there. You can see some fibers in type 2 injury, and type 3, you can see the fate also. So these are the different kind of injuries which can be because of urethral access sheath. So after this paper, this was published, I think in 2013. So we changed our practice from primary urethral access sheath to more towards minimal, no force or minimal force. Put a stent, then come out. After the stent, these injuries are practically negligible. Only the type 0 injury will happen. So these are the different calyceal and intracalyceal injuries because of bend, flexible scope. You are forcing into the narrow infundibulum, and you can develop these kind of injuries. Time है तो ये video दिखा दूँ. This was one of the learning experience for us. So this was a doctor who came for RIRS, inferior calyceal stone. So what happened to this patient? So it was inferior calyceal stone. We can see it was a fiber optic scope, initial days scope, and we can see the stone. It was lying into the inferior calyx. There, you notice that there are 2 or 3 dots on the vision also, black dots. These are the black dots. So like damage to the scope was already there. So we push hard. And whenever you are finding some difficulty in vision like this, wait for some time, stay there. Irrigation itself will work for you. So once irrigation is established from inside to outside, then vision becomes clear. We pass engage basket. So it's encircled. So you pass the basket behind the stone. So first time we failed to catch it. Second time, again we passed it and we able to catch the stone. So we thought that's a good thing. We catch the stone, we take it out and move it into the favorable calyx. But it got stuck. Then came out, and if you look now, the number of the black dot has increased. So what in this kind of situation, what you have to do, just open the basket handle, come out, and again pass flexible scope. And with the help of laser, you can break one of the wire with the laser, cut the wire and take the basket. Again, you can finish the job. So that's what we planned in this case also. We take the laser, try to cut the wire. But the number of black dots kept on increasing because of repeated movement into the inferior calyx. So finally, there was a blurring in vision. So we have to abandon this procedure and switch to PCNL. So that's the reason we should take consent in all patients for other procedures also. This is the another important slide. I kept it for the residents only because nowadays many digital scopes, disposable scopes are available, and people are more interested in buying digital scope because the cost is less, initial investment is very low. So these are the different manufacturer. These all scopes are available in India. Deflection, if you look at all deflections are same, 270 to 275, working channel is same. There is time limit in certain like unique medical devices. Initially they have time limit, but now they have stopped using time limit also. Litho, you still have 4 hours time limit. Boston Scientific, Biorid, no time limit. Fusense 4 hours. Again, they have changed it to, I think, no time limit. And Eagle Medical System 20 hours. Tip diameter is almost same. Shaft diameter is almost same. Chip technology is same. Cost is different, varying from 60,000 to 1 lakh. All these are available. So, but if you ask me about the life of these digital scope, it's variable. Again, ideally, these scopes came to reduce the chance of infection, not the reutility of these scopes. Because one of the reason for infection is reusability of the flexible scopes. So they came up with the idea that disposable laser fiber, nothing reusable should be used in RIRS so that there will be zero infection. So they come up with the disposable scopes, disposable laser fiber, everything is disposable and there is no infection. That was the basic purpose of coming up with these digital scopes. But we are using it many times and probably number is variable from 15 to 40, some claims 40 and some says. But so my take-home message is take proper consent, very important, no UTI, no force, DJ removal under general anesthesia, be cautious with stones larger than 2 centimeter and inferior calyceal stone. Thank you very much.
Thank you, Devendra. In the meantime, I would request Sanjay to get prepared. So definitely, I think Dr. Devendra has very well summarized and very important tips for the younger colleagues and residents. One is the foremost is the consent and counseling the patient. Consent nowadays is very important, and the consent is not just a simple consent, it's an informed consent. And it is a consent which is surgery specific, right? So surgery specific informed consent is very important. And we had come up with all types of informed consents, which is on our website also. When I was secretary in North Zone, I had put it on the North Zone website also. Now it is on the USI website also, both English and Hindi translations. And we had contributed a lot in that. So that is again very important. And the do's and don'ts definitely are very important. So particularly when it's more than 1000 HF. Again, if you have a good lithotripter, like in our center, we are doing less than 1000 HUs. Most of these stones are being done by our lithotripter, on ESW. So again, inferior calyceal stone, definitely a good indication for our areas. So I would request now Dr. Sandeep. Sandeep again is again very senior urologist, additional director, and a senior consultant at Fortis Hospital, Jaipur. Is doing a lot of surgeries. Particularly, I have seen your renal transplant and all those multiple artery surgeries, plus the laparoscopic surgery, the reimplantation of the ureter intravesical. That was wonderful. So, Dr. Sandeep, please.
Thank you, Kunja. I thank Department of Urology, SMS Medical College for giving me this opportunity to share a little bit about kidney transplantation. Kidney transplantation itself is a vast subject and cannot be summarized in a 20-minute, 30-minute talk, but I would like to share few of certain of my experiences. So we all know that for renal replacement therapy, there are three options: hemodialysis, peritoneal dialysis, and kidney transplantation. So what are the purposes of renal replacement therapy? To maintain the quantity and quality of life. And it should be the longest extension of the useful life. Why renal transplantation? When we compare the mortality rates secondary to sepsis in general population, let's make it 1. Then in patients of dialysis, it is almost 100 to many hundred times. While in patient of renal transplant, post-renal transplants, although it is 20-fold higher than the general population, but still it is 15-fold lower than the dialysis patients. And that is the reason we should advise renal transplantation to all our ESRD patients. So the outcome comparison therefore suggests that renal transplantation is still the best overall treatment for ESRD patients, despite so many advances in dialysis machines. And the data indicate that survival after renal transplantation is significantly better than that of patient treated with dialysis. The next question comes: when should we advise for the renal transplantation? When we look at the dialysis, those patients who have undergone dialysis for a longer period of time and then they opt for renal transplantation, the outcome is little poorer than those who undergo transplantation earlier. This effect is independent of age, race, donor characteristics, and original disease. It is probably related to fixed vascular defects on chronic dialysis therapy. Therefore, the recommendation for patients who reach ESRD should be that they should undergo preemptive transplantation, that is before the initiation of the dialysis, or transplantation ASAP once on dialysis. But the timing of preemptive transplantation should be such that the patient does not have months to years of usable function in the failing native kidneys. That is, we don't advise renal transplantation in CKD4 stage. It should be CKD5, usually with some symptoms of uremia. Then the patient should be advised to undergo renal transplantation. So how do we evaluate a patient for renal transplantation? How do we do a workup for the renal transplantation? First of all, the primary disease should be diagnosed as far as possible. It is not always possible because many of the times patients come with chronically shrunken kidneys, and even if we do a biopsy, it is not possible to find out the primary disease. But if the primary disease is known, there are chances of recurrence in the graft, and it should be well told to the patient well in advance. Every effort should be there to rule out any active invasive infection and to rule out active malignancy. There are well-formed guidelines as when can cancer patients undergo renal transplantation after the treatment of their malignancies. We should rule out a high probability of operative mortality, non-compliance for taking the medicines. We should find unsuitable condition for technical success. And finally, a good matching with the donor should be there. People always ask, what are the indications? Do we remove the native kidneys? And what are the indications for the native nephrectomy? Except for very few indications, we do not remove the native kidneys. The indications are large renal stones which cannot be cleared by minimally invasive techniques, a solid renal tumor which is suspicious of being a malignant, polycystic kidneys, especially ADPKD kidneys, which are extending below the iliac crust and therefore limit the space in the abdomen so that we can do a transplantation. There are certain nephrological conditions like persistent anti-GBM antibody levels, significant proteinuria which is not controlled, recurrent pyelonephritis, and grade 4 or 5 nephrosis, especially in cases of vesicular reflux and reflux nephropathy, which can lead to recurrent UTI in the post-transplant period. For the donor, the evaluation is aimed at ruling out any
probability or presence of the active renal disease, absence of active infection, there should be no transmissible malignancy, diabetes to be excluded. Now in high volume centers, patients with pre-diabetes and late onset diabetes are being considered as donor, but that has to be taken with a pinch of salt. There should not be any significant mental dysfunction, and a psychiatric clearance is must for legal purposes also. And the psychiatrist is the one who decides whether the patient can give a valid consent that he or she wants to donate the kidney. And there should not be any higher risk of perioperative mortality or morbidity, because donor is not a patient. He's a healthy volunteer who's helping his near and dear ones. So he should not be put at any risk. Now the next question which is asked by the families, what would happen to the donor if you take out one kidney? Now we should be very firm in assuring the donor that the renal function, the absolute renal function will be near normal after unilateral nephrectomy. But we need to leave the better kidney with the donor. The mortality rate is only up to 0.02%. Life-threatening or permanent debilitating complication risk is up to 0.23%. And there are only isolated reports of ESRD developing in renal donors. The hyperfiltration injury, which has been so often told about, is not significant in case of healthy donors. The remaining kidney grows a little bit, it undergoes hypertrophy, and endogenous creatinine clearance increases to 70 to 80% of the preoperative levels. And this creatinine clearance is sustained for more than 10 years. Development of late hypertension is nearly same as of general population, and development of proteinuria is negligible. So with all these facts, we can very well counsel the donor that the short and long-term risks of donor nephrectomy are very low, and the probability of successful graft outcome is very high. This makes the risk acceptable for fully informed donors. So how do we plan for the transplant? After the initial workup of the donor and recipient, the donor and recipients, they are admitted on day -1 of the transplant, both the recipients and donors. Usually the nephrologists, they start the immunosuppression, oral immunosuppression on day -1. Some nephrologists follow the protocol of day -2 immunosuppression. And before the day of surgery, we always follow audio-visual recording of the consent, wherein transplant coordinator, transplant surgeon, transplant physician, anesthetist, and somebody from the administration of the hospital is present in the consent. The donors and the recipient both are being individually counseled. Then their family is also made to sit in the consent, and everything is recorded. They are explained in their vernacular language, and they are the sign. All the documents are signed in the presence of under the camera. Once all these formalities are done and the transplant day is decided, how do we carry out the transplant in the OT? Now, donor nephrectomy is started first, and the recipient is wheeled in the OT at almost half hour to 1 hour later than the donor. The anesthetist established the central line epidural catheter and the Foley's catheter. In the meantime, donor surgery is continued, but we have to be very cautious that no irreversible step is committed. And what are the irreversible steps? Division of the ureter or any ligation of the pedicle. Suppose at the time of bed making, you feel that it is not possible because of some retroperitoneal fibrosis or thrombosis of the artery or vein or any untoward anesthetic event, we cannot proceed for the transplant. So the donor surgery can be stopped at that time, and except for the incision or port placement, no harm is done. The kidney has not been taken out and the donor can be shifted with both the kidneys inside. So while the donor surgery is going on, one of your assistants prepares the bench surgery and the perfusion table. In the adjacent OT, the recipient bed preparation started, which involves an extraperitoneal incision in the iliac fossa. Usually we prefer the right iliac fossa, but in case of second transplant, left iliac fossa is selected. The peritoneum is mobilized medially. Iliac artery and vein are skeletonized. All the lymphatics should be carefully tied or clipped. They should not be dealt with cautery only. because that would lead to formation of lymphocyte in the post-transplant period. And the urinary bladder is prepared for ureteric anastomosis. So this is the kind of draping we use for our kidney transplant patients. This first layer is the common green linen, which is available in all the operation theaters. And the second layer is the disposable surgical dressing, which is impervious, which has an iodine layered sticky plastic film in between. And over this impervious layer, we use a third layer of white sheets because all the sutures are blue, proline. And it is very difficult to see those fine sutures in this blue background of the disposable draping. So we use a third layer of white sheets over this dressing at the time of transplant, which increases the barriers also to prevent the infection and ensures a good background. This is how the bed is prepared. Many people use internal iliac artery for the anastomosis. My personal preference is external iliac artery and external iliac vein. This is the external iliac artery. This is skeletonized. The lymphatics are tight. This is the external iliac vein. It's only a choice about the artery. The vein is always external iliac vein by all the surgeons. This is how a perfusion table looks like. Initially, we used to have all these graters which are available in the kitchen. We used to get them autoclaved, and the sterile frozen ringer lactase is used to be grated by the assistant and to prepare the ice slush. Lately, we purchased this electrical ice crusher from Amazon, and it makes ice in a fizzy like this, a very good slush. So let's talk about the donor nephrectomy. The donor nephrectomy is a major surgery which is performed on a healthy individual or a volunteer. It has got no direct therapeutic benefit onto the donor itself. All the benefit goes to the recipient, and therefore the principle of first do no harm remains of utmost importance. Traditionally, donor nephrectomy was done by an open procedure which involved a large flank incision either by the 11th or 12th rib approach or by a subcostal approach sometimes. It was associated with significant pain and a prolonged recuperation period. And this was the post-operative result. A long scar on the flank side, which sometimes led to formation of pseudo hernias, which is not actually a hernia, it's a muscle weakness. And it is very troublesome to the patient and very difficult for the surgeon to repair also. So with the advent of laparoscopic surgery, it had been a quantum leap in the field of transplant sciences. And it was in 1995, Dr. Lloyd Rettner, he performed the first laparoscopic donor nephrectomy. So we all know the advantages of the minimal invasive surgery. They are less post-operative pain, shorter stay, early return to work and daily activities, a favorable cosmetic result, which is very important for donors in our country, because most of our donors are wives, sisters and mothers. And at the same time, the recipient outcome is absolutely identical to the open procedure. Now, there are two approaches for the laparoscopic donor nephrectomy. One is transperitoneal, which is very commonly practiced, and another is retroperitoneoscopic approach. So why retroperitoneoscopic approach? We know that kidneys are retroperitoneal structures, but it was very difficult to obtain an adequate retroperitoneoscopic space in the initial days. And it was none other than our own Dr. D.D. Godfrey Bombay, who revolutionized retroperitoneoscopy by developing an indigenous balloon. And I was fortunate enough to have met him and have treated him recently when he was admitted for a small minor ailment in our hospital. He devised a balloon in 1992, which is now labeled as Gore balloon, which is very cheap and which has absolutely revolutionized the retroperitoneoscopy world over. So retroperitoneoscopy, it's a more anatomical approach. There are absolutely zero chances of varus needle and port site injuries. There are no chances, minimal chances of bowel injury, adhesions, post-operative obstruction, internal adhesion, because the peritoneum is not violated. There is hardly any paralytic ileus in the post-op period, but it has got a steep learning curve for the surgeon and the camera assistant. There are very minimal landmarks for the guidance of the surgeon, except for the psoas muscle. And this is how the ports are placed in the retroperitoneoscopy. This patient is lying in the lateral position. This is the head end. This is the foot end of the patient. This is the marking of the 12th rib. At the tip, just below the tip of the 12th rib, the first port is established. Anteriorly, in the anterior axial line, 5 mm port is placed, and in the renal angle, another 10 mm working port is placed. These are the scars of one of my patients, actual patient. So this is a small video about how this balloon is prepared. So these are 2 glove fingers of a size 8 glove. Which are threaded onto the K90 catheter, and they are secured firmly with a silk thread. So the cost of this indigenous balloon is only say 100-150 rupees, 50-60 rupees for the catheter and 50-60 rupees for a glove finger. They are firmly tied to ensure that the water doesn't come out of that balloon while it is inflated. You have to throw multiple throws of silk thread around that catheter to ensure a watertight closure. And before inserting it into the patient's body, it is inflated with 50 to 100 ml of saline to check whether any water is leaking or not. And you will be amazed to know that this balloon will hold almost 1 to 1.2 liters of saline when it is inserted in the body. So this is how it is leak tested. So once this balloon is created, 1 to 1.5 centimeter of incision is given at the pre-marked place, just below the tip of the 12th rib. The space is deepened with the help of blunt and sharp dissections. Narrow and deep retractors are inserted. Next. Yes, sir. So this is how the primary port is placed. It is all done under vision. These narrow and deep retractors are placed to enter the retroperitoneal space, and then the balloon is inserted. You cannot see the inside view here because it's a very small incision and only the surface view is available here. This balloon is inserted and then it is filled with almost 500, 600, 900 ml of saline depending on the patient's body habitus. So all this space creation is not a costly affair and it's not a rocket science. So once everything is done, this is the kind of bulge which we see on the patient. And as soon as we remove the clamp, all the water comes out by the elastic recoil of the rubber glove. We can see here all the water is coming out. It is collected in a sterile container and thrown away or whatever. So once this almost 900 ml of saline will remove the balloon and you will see that it is still intact. This is the balloon which is still intact, although it should not be reused. So first port is then placed into this incision. A small piece of gauge piece is inserted, which is attached to a thread so that it does not get misplaced to ensure a CO2, there's no CO2 leak and subcutaneous emphysema is not produced in the donor. It is tightened, the CO2 gas is connected, and then all other ports are placed under vision. So the secondary ports are also placed like in a similar fashion, 5 mm port anteriorly and 10 mm port in the renal angle. Once all the mobilization is done, we plan a retrieval incision, which again is a small incision in the extraperitoneal space in the iliac fossa. The size of the incision depends on the size of the hand of the surgeon, because once the artery is ligated in the donor nephrectomy, the kidney loses its turgor. So it is not the size of the kidney, it is the size of the hand of the surgeon. My hand size is almost 7.5, so I make a 7.5 centimeter incision. Somebody who has a smaller hand will always make a smaller incision. Now this is the inside view of the retroperitoneoscopic. This is the gonadal vein which is being controlled with the harmonic. There is no need to use the clips here, and we can see the ureter going down here. All the tissue, it should always be an effort to preserve all the tissue between the gonadal and ureter, gonadal vein and ureter, so that the vascularity of ureter is maintained and there are very less chances of urine leak in the post-op period. The ureter is clipped, it is being cut, and immediately if you see a stream of urine coming out of the cut end of the ureter, that ensures you that the donor kidney has been handled delicately. There would be very less chances of infection of ATN in the post-op period. So once the ureter is controlled, the attention is then directed towards the renal artery. I control the renal artery with double vac clips, 10 mm vac clips. The beauty of retroperitoneoscopy is this, that the aorta is lying parallel to the ground and the renal artery is absolutely perpendicular. So all the clips are applied perpendicular to the artery, and there are very less chances that they are applied obliquely and they would slip afterward. The renal artery, again, we can see a good stump over the second clip here. Similarly, the renal vein is again cut, leaving 1 to 2 mm of stump above the second clip. The hand is then inserted. The hand is then inserted to the pre-placed incision. Kidney is taken out. It is placed in the already prepared ice slush and handed over to the assistant for perfusion on the cold table. So the usual outcomes in donor nephrectomy are, the time is approximately 1 hour and 30 minutes. There's hardly any blood loss in donors because the planes are always, it's a virgin plane. There is hardly any addition or anything. Almost always, if you have handled the kidney well, there is brisk on-table diuresis. Warm ischemia in case of single artery ranges between 1 to 2 minutes. Ureter, we always try to preserve ureter and its blood supply. If you have done your surgery well, there is no need for place the drain. Absorbable skin sutures are used for closure. Ambulation and oral diet can be allowed in the evening, and patient get discharged on day 2. So this is how the post-op cosmetic result is seen. This is a case with the retroperitoneoscopic donor nephrectomy scar here. This is a transperitoneal donor nephrectomy, 3-4 ports and a small incision here. And this is the result of an open donor nephrectomy. So we can very well compare how laparoscopy fares better compared to the open donor nephrectomy. So laparoscopic donor nephrectomy faced a criticism that it's not a versatile technique, but it is not so. It was initially so in the initial period, but not now. This is a case where we had 2 renal arteries. We retrieved with a laparoscopic technique only. We made a pantaloon of this kidney. This is how a pantaloon is looking like. Always try to make as much dissection or when the kidney is immersed in the ice. Because if you do 2 anastomosis, your rewarm ischemia time increases. That increases the risk of ATN. So it's always better to do as much bench surgery as possible in the ice and then do a single anastomosis on the recipient side. There is another case who had a venous malformation and 3 arteries on one side. So we opted for the left kidney, single artery, and It was done successfully. This is how the graft should look like when it is ready to be implanted. Artery and vein, all the jagged edges are cleared, excess fat has been removed, the kidney has been denuded, all the paranephric fat has been removed. The ureter with the gonadal vein with the preserved blood supply should be there. Another anomaly, vascular anomaly here, where both sides there were two arteries. We harvested the graft laparoscopically. This small branch was anastomosed end to side to the main renal artery in the ice slush, and then in the recipient and single anastomosis was done. So this is important that we should minimize the rewarm ischemia time to as low as possible. Well, we always prefer left kidney to be taken out from the donor. Why? Because in right side, the IVC is situated on the right side and the length of the renal vein is very small. And if you apply 2 clips to the renal vein and then take out the kidney, the length of the renal vein becomes very small. So right-sided laparoscopic nephrectomy, donor nephrectomy is difficult. In the open surgery, we always apply a Satinsky clamp to the IVC and take out a cuff of the IVC to increase the length of the renal vein. But on the right side also, we can do this, not applying Satinsky, but by applying a vascular stapler. I will just fast forward this video. So after the initial dissection, everything has been done. Further. So from now here, you can see the kidney has been mobilized. After the mobilization, if you see a little spasm, you can put up a pepperine watch piece under the renal artery till the time you make a retrieval incision and other things. A 4th port is inserted to insert the vascular stapler. This is the control of the ureter. You can see the urine coming out of the cut end of the ureter. And this is how the IVC. This is the vascular stapler endo-TA from Covidian. It is no more available now. The artery again is controlled with 2 vac clips. And then this vascular stapler is applied. It is pressed on the IVC to include as much of length of renal vein as possible. It is kept in place for almost 30 to 45 seconds to ensure complete application of the vascular clips. Then it is taken out. It clips on the, it has a 3 rows of staples. So it clips only on the side of the IVC. And the side of the renal vein is patent. And this is how it looks like. This is the stapled line of the IVC. This is the arterial stump. And this is the graft obtained. We can see the almost equal length of the renal vein and renal artery here. So even the choice of right-sided selection of right kidney is not a hindrance to pursue a right donor nephrectomy by laparoscopic approach. Recipient operation has not undergone too much change in the recent past as far as surgery is considered. Renal artery is anastomosed with external iliac artery with 6-0 or 5-0 proline. Renal vein to external iliac vein. Anastomosis time should be as short as possible. All your assistants should know your steps well in advance. Whenever you ask for a suture or an instrument, you should simply extend your hand and you should get the instrument. The kidney should immediately turn pink and it should become turgid after release of the clamps. Urine output should always be immediate. And once hemostasis and urine output is established, ureter is anastomosed to the bladder. Placement of DJ stand or drain is surgeon's discretion. I do my closures by absorbable sutures. This is another case where there were multiple vessels, 3 vessels on both the sides. So we opted for the left side. We controlled 2 of the vessels together, 2 of the renal arteries together, 1 separately. These are the stumps. This was how the reformation was done. One of the smaller artery was anastomosed end to side to the main renal artery, and the upper polar was anastomosed to the inferior epigastric artery. This was how the picture looking. This is the inferior epigastric, and this is the main renal artery receiving the smaller tree. So to conclude, laparoscopic donor nephrectomy is the choice of surgery for the renal transplantation now. It has offered many advantages to the donor. It has decreased the scare associated with the donor nephrectomy. It has no effect on the recipient outcome, but should be performed by an experienced laparoscopic surgeon. And on theoretical grounds, retroperitoneoscopic fares little better over the transperitoneal approach.
Thank you, Sandeep. It was wonderful. Dr. Sandeep is a master of retroperitoneoscopic surgery. So I've seen many of his videos, and he does laparoscopic. I've seen one of these intravesical laparoscopic reimplantation. That was again wonderful to see. Just I would add one thing when we are talking about creating a space in retroperitoneoscopic surgery. When we started doing retroperitoneoscopic surgery, we devised our own method of creating space. And what we did, Sandeep, just listen to it. We had put the finger, the glove finger, not on the K90, but on that trocar, disposable trocar itself. And that disposable trocar that we have put in, and then you can actually visualize the inflation. You put a telescope inside that trocar, and you can see how the inflation is happening. Even you can see the space which has been created under vision. So that was what we started doing. But I must confess that we are doing very little of retroperitoneoscopic surgery nowadays. We are doing almost all transperitoneal, our lap donor nephrectomies, etc. And about the recipient surgery, definitely people have been doing laparoscopic renal transplant surgery and now robotic renal transplant. And we also tend to start our robotic renal transplant in the first anniversary of our robotic. So next year, we wish to do it. So thank you once again, Sandeep, for that wonderful presentation. So by this, we come to an end. The chairpersons have something to put as a comment. In the meantime, I would end the Zoom and the YouTube link. And I would thank all our visitors who might have visited us on Zoom and YouTube today for this session of our masterclass in urology. So thank you, all of you. If anybody from you want to speak something, I can see a lot of people. Dr. Kim was there, Dr. So if you have anything, please put your hands up. Otherwise, we will wrap up the session on Zoom link. So thank you once again. So we will wrap up the session on Zoom.